Today's session will focus on implementation strategies in the context of existing priorities and requirements. Obviously, the reality of what is already underway in various loci is key to the success of the overall effort, and so we're going to engage that in some detail in the first discussion session. And then we'll turn to the infrastructure required for assuring the availability and comparability of the metrics at the national, state, local, and institutional level. So let me now, having, I think, stalled long enough so that people have found their seats, turn it over to Craig.
Oh, Michael, thanks. And welcome back, everybody. I just wanted to open up quickly and comment that what an intensive set of discussions yesterday was, if you really think through it. A long day, a lot of deep discussions, and congratulate Rob and the whole IOM team for pulling this all together and bringing us one page of a summary of the specific metrics or categories that were discussed yesterday. They did a great job of culling all that information out and bringing it together for us to review this morning. So I want to thank them for that effort, and all of you, most importantly, for the discussion and the contributions that led to this. So welcome back to day two. We have a great opportunity this morning to shift into the discussions of implementation and infrastructure. We thought before we do that it would be really useful to take a little time, have all of you look through this summary of the recommendations around the metrics that were made yesterday and the examples, and get some feedback on each of the sections before we start that discussion. And I just want to make sure and take care of a couple or a housekeeping issue. There are sign-up sheets outside for taxis to get rides to the airport. So they ask that you try and get signed up for any rides that you need before 10:30, which is, I think, the end of the break this morning. So if you can just remember to do that. So let's jump right in and begin taking a look at what was put together from yesterday's conversation. We have it broken out into sections. The first should be population health, I believe, and be glad to see that jumped to the top of the list instead of the bottom of the list. But if we please go ahead and take a look at this. It's broken out into two categories: current health and future health. And you can see under each that there's a list of example metrics that were recommended out of the discussion. Now, the most important thing is to look at this, particularly those that were in the group, and to see if this reflects what the discussion was and what the thoughts were that emerged from the discussion yesterday. And then any thoughts or recommendations back, anything you see that's glaringly in error or additions you think should be there. And we're going to take a few minutes on each of the sections and open it up. And I just want to make sure to thank the reporters yesterday who brought the information back to this group, because that was quite a difficult task to put all that information together and have it lead to this. So let me go ahead and stop there and open it up and see if there's any comments or thoughts around what was brought out for population health.
I think so it is interesting when you think about the conversation and then sort of play telephone game and see how it's translated. I like the fact that what came out was this concept of the current health of a population and then the future health. I think Matt's going to talk about that term, but I think rather than example metrics under future health, that perhaps there are two categories. One, which would be risk that's really intrinsic to individuals, can be measured at the individual level, health behaviors being a large part, but maybe genetic predisposition. And then a second category, which we might call extrinsic risk or community risk, which is really measured sort of on the social ecologic model on the outer rings. And those words are in there. So I would think that maybe if we had three categories, current health, and then individual risk and community risk might be another way to think about it, because we had a lively discussion about risk being along a continuum. And the words under examples do talk about health behaviors and then healthy communities, which really might be the same as extrinsic determinants.
Great, thank you.
I like the categorization as well. Just a couple of thoughts about it. With regard to current health, I think it would be valuable under quality of life to include a nod to self-reported health, which doesn't jump out from the point of view of the person. My favorite quote from John Ware is, if you want to know how Mrs. Smith is doing, unfortunately, you're going to have to ask her. And you know, that could be missing from this. You know, we debated this notion of future health, and it might be worth testing to see how this framework fits. But a lot of those environmental determinants, and even including the intrinsic risk factors, are things that affect and bombard people in the moment, not necessarily just as it's affecting their future health. So I'm not sure health determinants apparently doesn't resonate well in terms of communication, but we might just want to play with that terminology.
So yeah, so we're thinking maybe of a different term than future. Yeah.
Right, maybe a different term than future. Although they, you know, in Wisconsin they've played with health determinants and health factors, and neither of those things resonate terribly well either. But so it's something just to think about.
Has anything popped out that seems to fit as a better term, capture it a little better, in your experience, your discussions?
Well, when we talked a lot to people in the media and policymakers in 2010, health determinants did not work. So, you know, most people couldn't pronounce it. So we then changed to health factors, which I think is easier to talk about. But so that's the terms we currently use. I think, Matt, for explaining it, we said these things tend to predict how healthy you will be in the future. But you're right, they are not solely future health factors. And then I just think mostly from Gene and others who are looking at measuring risk, I don't know whether risk, we haven't really talked about sort of individual risk and community risk. That might or might not work. So I think the concept of risk is important in that it's measured in the present, but it predicts outcomes in the future. So if I had to pick one rather than future, I would think these are health risks of individuals and of communities.
But it includes positive stuff.
Good point. Good point. That's why it's a factor.
Would health influences? Yeah. All right. Thanks.
So I think my comment's similar. And I think I really came up to the microphone to really say that I thought the individual factor is not quite as emphasized. And I think that's what you said, because that part of the discussion that really had us thinking about a spectrum from person to whole population, you know, is not missing. Seems to be maybe it's there, but it doesn't seem to be jumping out. Let me put it that way. And then the other thing around individual risk behavior, risks, we had some conversation about place-based risk and whether we could figure out how to do that. And I'd hate to lose that particular idea, at least to try to test it. You know, place-based risk meaning something like if you live in one state that has a higher rate of crime or a higher, you know, alcohol-related automobile accident rate, how do you express that? Is that meaningful, or is it a useful way to do that? So that sort of idea. The second thing, I think we ought to accept Steve Teutsch's suggestion in his paper to label this total population health, if we mean the whole population. And then maybe we have more than one diagram, more than one table that speaks to subpopulations, since this is sort of a conversation between public health and private health, and we've got the whole population versus the subpopulation concept that Steve also mentions in his paper. And so I would ask you, Craig, and the committee and the IOM staff how we're going to deal with that notion with a single representation, not only for health, but the other two. So population health at the level of an ACO is not going to look like this, I don't think, totally. But it's going to not look like individual health either. And so how do we deal with that? If you think of the minimum requirement for an ACO being, was it 5,000 Medicare beneficiaries? What can you do with these kinds of measures with 5,000 Medicare beneficiaries, or the private sector sort of implementation of ACOs with non-Medicare populations, with populations that vary up, into the perhaps hundreds of thousands. And then special subpopulations with particular kinds of risks like Medicaid, which don't have a risk profile like the general population and so forth. And so since we've talked about those concepts, how are we going to reflect that is my question in our product with notes or and if we label this population health, does that mean subpopulation health, which is what Steve proposes? Or if we label it total population health, is that total geographic population health? How do we deal with those issues? So I hope those are useful. And then on the implementation side, we had some discussion about health risk assessment at the individual level.
Right.
My comment is related to the actionability of measures. We had, towards the end of our discussion, sort of a recognition that if the metrics are set up to really drive action, we do need to sort of tie it to decision-making of what's being invested in communities or in populations specifically. And that drives the need for what I would call a process measure. And I'm sure that people are cringing now. But a process measure that relates to making sure that those decisions have legitimacy in communities, that there is transparency of those decisions, and that those decisions are reported back to the community with a level of variability, if you will, around that decision. And I would call that a process measure, but it is a piece that sort of ties into the decision-making of which resources to invest and how to make sure that the community and the population is represented.
It's an interesting idea.
So I guess I was looking for some inclusion of the concept of equity and in population health, and I'm not sure we really covered that in our discussion yesterday, but I don't see it here.
Yeah.
I think it probably falls under both current and future health, but some sort of, not just looking at the mean levels, but looking at the dispersion around that mean and who's falling out where.
I had a similar thought about health disparities, but related to that, what George said about subpopulations, is that we make sure we're looking at uninsured people as well. And I think this might be a place to get that in.
Yeah. Thanks. And last comment, we'll move on to the...
I guess I would just echo those two prior comments with regard to equity and insurance status. One of the things that it seemed that we said yesterday in the group, which was different than perhaps what the Wisconsin group was doing in putting together a total health outcome metric, is that we made the job simpler since there was this care committee for the triple aim, and then you've got the per capita cost committee for the triple aim, and now population health could sort of be independent of care. On the other hand, to the extent that you're representing environmental aspects that influence health outcomes and health status, I'm wondering whether or not there might be some measures of access to health care and perhaps something that would be the proxy, which might be per capita PCPs or primary care providers or something else that might serve as a proxy for something that should improve health.
And just to clarify that, if access is included under the health care domain here, your concern would be it may not reach the people who aren't answering this in the healthcare setting?
I'm not sure that there's not some overlap in the Venn diagrams here, but I basically think that if you're going to talk about environmental forces that influence health, without getting into the nitty-gritty of process or outcome measures, that some sort of measure of the health resources, health care, health delivery, forces in the community might be useful.
Got it. Thank you. Okay, let's move on to the next section, the healthcare section, and here you can see it broken down into the categories of patient-centered, effective, safe, efficiency, coordination, and communication with some example measures. And let's do the same. Let's just go ahead and open it up for comment.
Hi. Oops. Too short. Lisa McGifford with Consumers Union. In our discussion, I think that a lot of issues under the example metrics got sort of taken out. That there were some listed in the original document that I think people wanted to retain that maybe didn't get retained. For example, under patient-centered shared decision-making, you know, there was a whole list of issues that I think the group probably assumed would stay there and that these were additions.
Okay.
I'll let other people in the group speak, but I know for myself, we didn't talk about every single issue under the metrics, but there was consensus that those were good issues.
Right. So one thing to just comment on, there will be opportunity for back and forth with the IOM team as they're putting this material together, and we want to make sure that those get added in. Thanks.
Thanks, Craig. Two areas. First, under effectiveness, I think that would be a good place to capture the concept of appropriateness of care measures. I see that you have that under the implementation, but it's such a critical area. I think that might be useful to put it up into an example concept at least. And then under the safety, I really like the composite medical harm measure. Would it be possible to expand that a little bit, because inappropriate care or overuse measures, those concepts also contribute to harm because they expose people to risk. I think of it in some ways like defects in care in a general sense, which could range from overuse to actual causing infections. Right. And lastly, under efficiency, you know, clearly ambulatory care admissions and readmissions are key. Emergency room use kind of falls in the same way. So if a population is overusing emergency or conditions that might be treated in offices, could be a sign of access problems or inadequate primary care or other defects in the outpatient.
So from your perspective, would you look at that as overall ED use? Would you look at it as avoidable ED use? How would you categorize that if you had to?
So the emergency room doctors, when you talk with them, they don't really like this avoidable or preventable ER use concept. I think others do like that, and I know there are some already some conceptual framework there and some lists of conditions that could be treated as outpatient but wind up as inpatient. So I think that might be a place to start. It's like a lot of things. You can look at the general case and say, what's the overall risk-adjusted emergency room use? Right. And actually, I'm working on a measure for that at United. And that could get at things which are borderline, but at least the things that have some consensus behind them that are not necessarily emergency room level of care.
Great, thank you.
Thanks.
So I guess I have two comments. I was reminded that my question is how we're going to, if we're going to incorporate this notion from yesterday of how families and core sets fit into this, or is this the core set, is my question. And I made a comment yesterday, I won't repeat it. I was trying to figure out, just looking at the list, how that might work for nursing homes And their core set might work for hospitals, might work for cardiologists, just to pick a couple. But this isn't quite structured that way, so I don't know if this is an appropriate comment or not. But I think one of the challenges we have is in terms of what the definition of core set and if we're going to use families is, and then how the sets are actually operationally defined for real institutions that have responsibility for real patients. So that's one comment. And then the second is I'm aware that that there's an IOM study starting up where public health, one of the subpopulations in that subpopulation, actually has categories that add 3 to these, I believe. I don't know what they are. And so how does this apply to public health or not in terms of quality improvement for public health? I don't know if that's an appropriate question or not, but it's a question in my mind. This is the medical care one, and if one of the subgroups is public health, and we want to encourage public health and private health to work together, does this framework embrace, is it broad enough to embrace both private health and public health?
So George, along those lines really quickly, does the overall, if you add them together, you look at the population health and you get into the second section and you add that to this, does that begin to take in the public health considerations?
I don't know, because I actually only know enough about that other framework. You actually know everything I know about it. But, maybe there are others here that can really talk much more to it, and whether my comment makes any sense at all or not. But that's a question in my mind at this point. If there's another explanation for it and it's covered another way, I'm happy to withdraw my comment.
Yes, hi, Judy Murphy from the ONC. 2 comments. The first one, I'll echo Lisa's comment. I think when we added and discussed these example metrics, we were not meaning for them to replace the ones that were on the sample document created by the staff, but they were really meant to be additive. And particularly in the area like coordination and communication, transitions of care and handoffs are just like really important, and so we have to make sure that we get the metrics back in for that. Okay. And related to implementation, we had a fair amount of discussion. I think it's implementation. It could impact the metrics. A fair amount of discussion about setting making a difference and being very clear on, identifying what the appropriate setting is. I think we talked about the least disruptive location or the most accessible, least expensive kind of idea. So I think incorporating the setting concept somewhere in here would make sense.
Thank you.
Natalie Landman from ASU. I just have more of a general question, I think, to the group. I don't want to talk about specific metrics. What I'm hearing from the discussion yesterday and also today when we're going through is that some people are here at this really high-level stuff and others are really deep down in the weeds. And what's not clear to me is where do we want to be? What do we want these metrics to actually help us accomplish? And I keep going back to my own experience as a molecular biologist where I know 5 different ways to run a Western blot. Do I have to have somebody tell me what it has to be at every step of the way, or do I just want to measure the outcome? And then if the outcome is different, then I go back and study all the processes. So I don't know if it's a really naive or stupid question, but what do we want to do with these metrics? And I think that will maybe help us figure out, do we want to be at the 50,000-foot level, which we then can roll down and figure out what works, or do we really want to go down deep and create 500 metrics that help us figure out every piece of it? I don't know.
That's a good question for a future discussion. Thank you.
Hi, I've got 3 comments. The first one's about efficiency. So in our cost discussion group, we actually talked about efficiency as a subset of cost, and we also used the ambulatory care sensitive admissions as an example. So we have to, I think, figure out where we want to put efficiency, and I guess to some extent it's arbitrary, but if you think about the model that was put out yesterday about population health plus experience of care divided by cost equals value, it seems to me that this particular component belongs in the denominator and not in the numerator. So it's something to consider where that block goes. Second comment is, I know that we intend equitable care to span all of these.
Yeah.
And it does so by means of example, but perhaps we want to make it more prominent by maybe having a banner equitable that runs down the side of the other so that it's not simply an example, but rather a metric itself. And the third comment with regard to coordination, I realize it's just an example, timeliness, but there's more to coordination than timeliness. I know you can accomplish a transfer to the rehab unit in a timely fashion, but if nobody knows why the patient's there, what medications the patient's on, or has any idea what's going on, that's really not coordinated. So we need another, I don't know, perhaps better completeness of communication or effectiveness of communication. Something needs to be there to highlight that.
Thank you. And we'll ask everybody, please keep your comments as brief as you can. Which is great. We're going longer than we thought, and we just want to make sure to have time. But thank you for all the input. It's great.
I had slides, but I won't show them. On functional status, and I would broaden that to health state. And I think it should be health state going into healthcare and health state coming out of healthcare. The difference is important. And I don't think that's covered really on the timeliness part. The other thing is risk adjustment is critical. I think this is really a significant issue here as to whether or not you want to readjust. Adjustment can be used to hide purposely or inadvertently. So it's not clear to me that that all measures should be adjusted in some fashion.
Thanks.
Couple of quick comments. The first is, I think in our rush to get to things that were new and cool, we maybe left out some of the key health outcomes that we're sort of used to. When I look at this and I think about the work I do as a doctor, there's very little here that is the core of my management of medical conditions. And so I know that that's only one part of this, but it feels like it's not very well represented. And I don't know how to roll all that up, all the care that's provided all across the country rolled up into one giant number, but it feels like there isn't much of it here. The second thing is I'll advocate again, I advocated for yesterday, some large measure of how much modifiable risk has been modified, which seems like a sort of way to get at that in a giant roll-up fashion. If that's what we're about in healthcare, especially in the preventive range, some way to quantify, are we moving forward in modifying the risk that we care about?
Thanks. That's a great point.
Yeah, just to comment on the effective category, which relates, of course, to appropriateness of care. They're very closely tied. We had a distinction yesterday between cross-cutting measures, which apply to a lot of these categories, and condition-specific measures. And that's very important in the effective category because mortality, functional status was a generic instrument such as the SF, or those are cross-cutting outcome measures that can be done. On the other hand, a number of measures are emerging on the process side, which are being produced by professional associations and were being implemented right now in different disease categories that are condition-specific, and that they resonate with the people who are doing it. So,
yeah, it seems like one of the things we're going to need here. Some of these comments also relate to the analytic methods that are applied to the measure, and so probably we're going to have to address that, such as the adjustment question and general overall versus condition specific, so on and so forth. Yeah.
Barbara Gage, Brookings, also quite short. Here we go. I would just like to. This is a framework, right? This isn't a comprehensive set of measures because there are quite a few. If we look at the third column over, those are example metrics, and there are many that are not there, kind of building on some of the comments that have come up, particularly under coordination, where we just have timeliness, and as was mentioned by someone before me about the med reconciliation, about the communications across the providers working with the patient, that's very important. These are just samples.
Yeah, these are just examples. And again, I think we'll have to have an effort to reach out and fill in fill in the different blanks.
I was really hoping that somebody would say this so that I wouldn't have to, but just to point out the obvious, effective, those measures are the same measures that we have under population health. And so I think the same with, as Richard was saying about efficiency, efficiency can be thought of as the relationship between care and cost, and effectiveness can be thought of about the relationship between care and health. And so I think we need to think of the triple aim as a whole, because those measures are the same as the measures of health.
No, thanks, Matt. That's right. All right, last question for this section, or comment?
Small comment. I think functional status is a measure of a patient-reported outcome nature, and so there's a bunch of different patient-reported outcomes, and my suggestion is you generalize it to patient-reported outcomes, and functional status is an example of that.
Right. Okay.
There are also clinicians as functional status that are just waiting for that.
All right. Okay. Let's try and quickly gather comments on the last section costs so we can move into our discussions, and I really appreciate all the feedback. This is giving the team a lot more work to do.
Okay, my comments are with regards to the second section, that's total cost of care standardized, and then the word utilization or relative resource use. I think it may be obvious that second category is not looking at unit price, but it is more looking at utilization when you neutralize it, but I'm not sure if that is that obvious. So I'm not sure where we should put the word utilization or resource use so that we don't lose the fact that we're not just talking about looking at unit price here.
So let me ask you a question. There are some that would offer that good health services can affect utilization, may not affect cost, because there's business layers between utilization and cost. So to answer that, would utilization be better reflected in the health care domain, or is it better reflected in the cost domain?
Well, I think when we're calculating total cost of care, it's cost and utilization in that calculation. So I don't know how the group would feel. I would almost prefer to see it under cost, okay. But I may just be one opinion. But it is part of the equation.
Thank you. Thank you.
This is higher than my head, so I'll pull it down. On the third category, affordability, I don't think there's a need to specify federal government health care as a federal government spend. We're talking about total spending on health care. So instead of national GDP alone, put state, community. Right. You know, we're not, and the percent of household spending on health, that is premiums and out-of-pocket, so you don't need to do separately premiums down below. You know, so it's make that category just a little simpler. Mm-hmm. So to convey the sense of why we have so few in cost, somewhere it should be said that the way we've collected this allows us to drill down. So we weren't saying we're only going to look at total spending per person or use-adjusted spending per person. We want to know the prices. We want to be able to drill back down to, was that spent on surgery, ED? So it wasn't getting rid of that. It was collected in a way that we can drill down.
Great, thank you.
I wanted to, first of all, support the first speaker's comments that the second category, we had specifically talked about resource use, and I'm looking towards Sue Knudsen, right? So it's resource use, and standardized costs would reflect that, but it's just to have clarity of what we're looking at. And then we had a long discussion as to whether we're talking about costs or expenditures. Mm-hmm. And I just asked the other group, where's our economist? That's right. So that by the time that we got through our discussion, it was, I think we had really settled on actual prices and actual expenditures. Right. Just so that there's no question. Yeah, actual spending as opposed to actual costs. Great, thank you.
Thank you.
That's exactly what I was going to suggest was spending.
Yeah.
I wanted to comment on resource utilization. I do agree it belongs here, but I think the reason why it's so hard is because it's divided into appropriate resource utilization, which could be argued to be effective care, and then inappropriate wasteful utilization. And maybe we need to have some reflection here of a metric of waste. I don't know if it would be a metric or an example, but I would like to have that concept captured somehow.
I was going to say the same thing about spend, but I also think nowhere in here or in the healthcare side, I think maybe there needs to be a separate little box somewhere about value. And I know we don't have measures of that, but there's no connection here. I think all of us in the room kind of intrinsically understand that value is sort of baked in here, but for a broader audience, I think it needs to be pulled out. And the issue of coming up with measures for this course set that not just help the policymakers and other stakeholders understand the cost and the spend, but to help consumers and employers know and see variation and be able to make choices, looking at the cost and the quality together.
Thank you.
Hi, Howard Epstein from ICSI. And to follow up on a couple of the comments about the utilization, although you calculate utilization within the cost of care methodology, it's really a measure of health outcomes. So to broaden the category, you might think, instead of waste, talking about underutilization and overutilization as broad principles to measure the efficiency of the healthcare delivery system.
Thank you.
And I would just add, under the affordability, we have the percent individual employer Medicare, but we don't have the other non-payers that are all part of that affordability equation, the uninsured and the...
So self-insured and uninsured, you mean? Or?
Mm-hmm. And Medicaid. I mean,
Yeah.
if you have Medicare, say public spending.
I know the group debated and rejected the inclusion of public health expenditures. Just one opinion, I would argue for including it back in, that because of its leverage, thinking in the triple aim on the health of the population, it may have more leverage than cost of care. And I think we need to look at both, especially if we're looking at the distribution and trade-offs among them.
Yeah, thanks, Matt. Okay, last comment.
Hi, Andy Hackbarth from RAND and CMS. I'm actually not sure if this is the right moment to ask this question or make this comment. It's not really related to the cost section or the others, but I did want to mention, periodically folks ask me what's a good measure, what's a bad measure, and I always ask them what exactly you're going to use it for. And this might be an echo of the microbiologists or the molecular biologists comment before, but we're talking about things like risk adjustment, timeliness, process versus outcome, where the answer to what's appropriate depends exactly on how it's going to be used. So do we imagine that these are going to be used by, these measures are going to be used by, say, the secretary or Carolyn Clancy or the administrator of CMS to set a national agenda? Are they going to be used by state Medicaid agencies or payers to create incentives for providers? Are they going to be used by leadership of providers to identify waste within their system, for example? Depending on the use, I would say it's potentially a different set of measures. And I still don't know, maybe I would put it differently. I think one of the things we should come up with is a set of use cases where we think these measures, if we're successful, will allow different stakeholders to do the things on that list. And it's very difficult to talk about what's a good measure, what's a bad measure, without knowing those use cases and to be able to test whatever output we come up with out of this against those use cases.
Thanks.
I don't think we've discussed this, but I'd like to make a suggestion for the framework, because we're going to put this out as an example, so we might want to think about best practices. And I would like for us to consider having a column of balancing measures, because I think a best practice would be to look for unintended consequences, and that's something that's been neglected, and here's an opportunity to maybe set out a best practice.
That's interesting. Yeah. Okay. All right.
if we were putting this out as a framework, I think that by putting value under cost, we've buried it. And really, we're talking about an equation where value is the result of the cost, the health, et cetera.
An overarching thing. Yeah.
Just two editorial comments. One is that it feels to me like one of the challenges of this process has been that it hasn't been clear to me, at least, that we all share the same definitions or understandings of the words we're using. And I've heard sort of shifting frames, like the value thing. I think it was two concepts that are mixtures of these, not separate ones. And yet value is showing up under one of these categories. So I think there's an opportunity for some perhaps better definitional rigor in this process. But the other comment I wanted to make was in response to, I guess, Andy's comment about, what's the purpose? What I heard when at the kickoff for this meeting yesterday is that we're really trying to set some goals, if you will, and that those are goals that would organize the work of the complex system that is in healthcare. And I'm going to go back to George's quoting Paul Plesik's Appendix B in Crossing the Quality Chasm, because he describes three categories of simple rules: goals, incentives, and boundaries. And the idea with the goals are that that simple rule is what the system is trying to achieve. And I see these metrics as being sort of a small set, hopefully a relatively small set, of things that everybody in the community can say, yeah, we want to achieve that. And particularly that the care delivery system says we want to achieve this, because I think that's where we need to see change. We're not going to have a affordable, safe, high-quality healthcare system until American healthcare providers change what they do on a day-to-day basis. And we need goals that they will sign off onto and buy into, and that they will work to achieve. We need incentives that will reward them for achieving those goals or moving towards them. And then we need the boundaries, the simple rule boundaries that say, here are the things you can do in that process, and here are the things you can't do. You can't, save money by you can't just be a high quality system by only taking care of affluent people, for instance. So, thank you.
Thank you. So, I think we need to move on to the next section. I just got an F as a moderator, but I want to thank all of you for the comment and the feedback, because this really is the input that's going to help refine the product coming out of this meeting. So thank you all very much. And let's just quickly then transition, if we can. I want to turn the conference over, and I'm sure the IOM team will be happy this will happen. We get back on schedule to Diana Dooley, Secretary for Health and Human Services here in California. And she's going to open up our session on implementation, and welcome.
Great.
Thanks.
Do you want to have the panelists come up?
Sure.
Why don't we all come up over here and try to...
There we go. Thank you.
It's very much my pleasure to be with you today. I had said to a few people last night at the reception that I feel like I've gone to a foreign country. I'm in a deep immersion class, and the person that said about unifying the language, you're all speaking a language that I don't speak. And so it's been fascinating for me to hear all of this conversation, and particularly I was going to take a few minutes and tell you about a process that we went through over the last 6 months, but in the interest of time, I'll just summarize and certainly make it available to any of you that are interested. But I came to this job as secretary in January of 2011, and in the first year and a half, I just, as happens in a secretary's Secretary's office, everyone comes to meet with you and tell you what wonderful things they're doing. And oh, by the way, if you would just make everyone else do what I'm doing, the world would be wonderful. And so after a year and a half of that, it occurred to me that we needed a process for sort of collecting all of these wonderful things that people were doing, and a system for measuring what would work and what would make the system better. And we used the triple aim, and we established a task force in June, and Don Berwick has been the co-chair with me, and it's been a great privilege for me to work with him. And many of the people that you would know that were new to me in the measurement category, I looked at this naively at the outset, thinking there were scores of measures, and discovered quickly that there are hundreds and perhaps thousands of measures. And through a very concentrated effort that was by design limited, we were tasked to do two things: to come up with some measures that we could use to set as targets for 10 years. This started rather simply with some people that were very engaged and wanted to set some aspirational goals for California to be the healthiest state in the nation by the end of the decade. And they wanted to reduce obesity, and they wanted to improve asthma, and they wanted to reduce sepsis, and they had some very specific things. And that sort of made sense, but it seemed arbitrary to just pick their ideas. And so we went through a process, and we came up with a framework that is being finalized now and will be presented on December 19th, and I'll be happy to send it to any of you. But we organized in much the same way we're talking about here, and came up with sort of 6 goals. And I'm not a PowerPoint person, so it didn't occur to me to bring slides, but there's a very pretty slide that will be in the report, and you're welcome to look at it. But it's a circle that has 3 things on the outside and a Venn diagram in the middle, and underneath it all, it's reducing health disparities. And the 3 broad goals are healthy beginnings, living well, and dying well. And the intersection of those are redesigning the health system, creating healthy communities, and lowering the cost of care. And we reduced all the scores and scores and scores of metrics that people proposed as things that would lead us to a conclusion that we had met those goals. And we have about 40, and we have 40 indicators that are grouped into these categories. And our intention is, over the next 10 years, to periodically measure and see whether these particular target goals that we have established are truly representative of our overall goal. But we started, and I look every year at the Commonwealth report of the 50 states and where we land in the various categories, and I look at the Wisconsin data on the counties, and I thought it would be pretty easy to come up with something that we could really say we were the healthiest state. I'm quite convinced now that that's an aspirational goal for us to be the healthiest state, but there aren't 2 states that we could compare with and really determine how we stack up against other states and what those measures are. And this experience with you all today and yesterday has really helped me understand the complexity of this process, and to the speaker about what it is we're going to measure and who is going to follow it and what is going to be reported. I'm intrigued by the years and years and vast experience that you all bring, and your persistence in seeking this holy grail. But I am very glad to be with you and to learn from you and be your partner as a policymaker who will use the work that you do and want to continue to seek this what appears elusive goal, but it certainly part of the journey is the journey. The goals will continue to move, and our goals over the next decade, even though we're establishing now, will continue to move. But talking about what we think is important is the most important part to me. And so it is my pleasure to be with you, and I appreciate that. And I'm very eager to hear from our very distinguished colleagues here with us today, and to focus on how do we bring this to something implementational and that we can answer some of the questions that have been raised. Pat Remington, Dr. Remington is the Associate Dean for Public Health and a Professor of Population Health Sciences at the University of Wisconsin. His current research considers how to measure the health of a population and the determinants of their health. He also has examined health disparities and how care quality and health varies by education, race, or region. In addition, he's examining ways to use this information in community health improvement, such as through the publication of the county health rankings. Before joining the University of Wisconsin, he was the chief medical officer for Chronic Disease and Injury Prevention in the Wisconsin Division of Health for nearly 10 years. Stefan Gildemeister is the Director of Health Economics Program and State Health Economist for the Minnesota Department of Health. He has directed the research at the Minnesota Department of Health in Health Systems Finance, Organization, and Coverage. He currently directs the department's work to improve the transparency of cost and quality, which relies on Minnesota's all-payer claims data set. He also provides policy advice and analytic guidance to Minnesota's implementation of the Federal Affordable Care Act. And we have Carole Romm with the Oregon Health Authority. Carole currently directs Oregon's accountability and quality efforts and reforms for its Medicaid population with a focus on new delivery system models. Prior to her role with the state of Oregon, she was Public Affairs Director at Central City Concern, an agency serving homeless adults in Portland, Oregon. Previously, Carole was the Health Services Director at CARE Oregon, Oregon's largest Medicaid managed care plan, and is a former recipient of a Robert Wood Johnson Foundation Nurse Executive Fellowship. Thank you all, and I am very eager to learn from you this morning as well.
So great, thank you, Diana. I see the time actually clicking by here. So what I'd like to talk about is how we actually have practically done this, measuring the health of entire populations across the nation. But I'd like to do a bit of research. How many people here have, before today, heard of the county health rankings? So how many people have gone to the website, countyhealthrankings.org? So a fair number, okay. So what I'd like to talk about is the methods we use, the results, and then talk about the implications. And this is fundamentally how we measure the health of a population. We consider that to be the health outcomes as we talk today. That's kind of the current health. We know that health outcomes are determined by factors. This is what we used to call health determinants. And this is an area that's under development. We know that you can work on the various health factors, kind of the social ecological model, things we do, programs and policies. And this is kind of our simple logic model. You do things focused on the health factors and you influence health outcomes in the long run. We measure health outcomes using mortality measures and morbidity measures. And one of the things about the county health rankings when we got the RWJ grant, actually we started this in the early 2000s in Wisconsin, is we just had to do it. We could, I think if we had had a committee and this many people in the room, we never would have developed the county health rankings, because you cannot decide. Whenever I ask people advice on how we should do it, I got 10 different ideas and all of them equally valid. So Dave Kindig and I just shut the door and came up with these measures. They're not perfect. We use years of potential life lost as our mortality measure, and we've come up with four measures from the BRFS: self-reported health, physical and mental unhealthy days, and then we use low birth weight, which is kind of, as Diana said, the early beginnings measure. We also came up with a model for health factors, and the size of the blue box is proportional to the weight in our model. Health behaviors, our individual health behaviors are important. We used, in the Wisconsin model, we only gave health care 10%, but George used to argue that that's maybe what it was, and maybe could we get a bigger piece of the pie if we took on some responsibility. So we changed it when we went national to 20%. And some of our modeling actually suggested that health care does contribute to health outcomes more than we had originally thought. 40%, the foundation of a healthy community, obviously, are strong social and economic factors. And then we don't measure the physical or built environment well, but we think that too is important. And in fact, if you look at these blue boxes, that's the social ecological model really unpeeled, right? Individual health behaviors followed by family, community, clinical care, social and economic factors in the broad environment. And these are our measures. Again, they have to be readily accessible, hopefully free, that we can get for all or nearly all of 3,000 counties in the nation. So we have lots of behavioral risk factor data. We would really like to have better measures of clinical care. And so my lesson learned here is that if we could come up with cost and quality of care and actually insert the 2 parts of the triple aim for all 3,000 counties, that would be great. We work with Elliot Fisher to get a lot of the healthcare data. But I like the idea that access to care, insurance rates, really, from a triple aim perspective, aren't really a matter. It's the quality of care of people in our system, but we think about access as percent of the population insured. So this is really cost and quality aims. This we think of as our health outcome aim, really a mix of mortality and morbidity. And this is what we talked about this morning, really, as the health determinants, or sort of an intrinsic aim, risk. And these would be then the health determinant aim, but extrinsic, or community risk. So you can really see that the model we've used maps quite well to the discussion that we had this morning. I do think when you talk about process measures in healthcare, we haven't talked much about process measures in communities, things that are actually done in communities that influence health determinants. And it would be great. Small community health officers talk about, we blame them for the health with the cards they've been dealt. They'd really like credit for the things they're doing. Could we measure some of the programs, some of the policy processes in communities and give them credit for at least doing the right things? So this is the map that I never show, except in rooms where people promise not to let others know that our county health rankings don't have to rank within state. This is one of our measures, YPLL. And you can see in the upper Midwest, in the Northeast and parts of the Northwest and West, these are the healthiest counties. I think 250 counties with the lowest premature death rates, and then in the Southeast and Southwest and predominantly Indian reservations in the upper Midwest are some of the least healthy places in the nation. We decided early on, and again, this gets back to the comment about for whom are we doing this. We knew that public health is organized at the state level, that if we ranked this way, and by the way, the media, when they call, the first question is, where's the healthiest place in the nation and the least healthy? And my staff don't ever tell me the answer to that question, though I figured it out now. It's actually in New Mexico is the healthiest county, Los Alamos, and in South Dakota is the least healthy place in the nation, one of the Indian reservations. But if we did this, there'd be one story, it'd have a national perspective, and it'd be the end of the conversation. As opposed to this story, which is ranking within state. In effect, it's controlling for state effects. So controlling for state effects, we can talk about Wisconsin. We've got some places that are really healthy and others that are unhealthy. But we can also talk about Mississippi, state of Washington, New York. And what we found is that if you change the perspective and the comparison, really, and use a measure like premature death, which is available in every county, you can drive the discussion to states. And in fact, we hear a lot of counties that have now taken on the task of being the healthiest county in the state, or some counties moving out of the basement from being last or in the bottom 5. As you know, we'll release this March 20th again this year. This is an annual project, and RWJ has signed us on for, just to say, a long time to continue to produce the county health rankings. It's helped that communities know that this is something that will be there for the long run, and there's lots of interest nationally and as well as in local media. The other thing we found is, as I've heard this term integrator, is that the rankings force integration, because by having so many different measures in the model, the call from the media to the local health officer, he or she doesn't really feel comfortable answering the questions about quality of care, perhaps, or if the call goes to the hospital or the medical society, they don't really feel comfortable about talking about education rates and the built environment. So we've noticed in some communities teams beginning to form that can talk about the rankings, and then slowly move towards action. This Institute of Medicine, you'll recognize this as really the Institute of Medicine future of public health model of integrators, again, the community members, and then this process of quality improvement in communities. This is our model. Now, if you go to the website, you'll notice that we're not just about problems. RWJ has funded us with another project called the Roadmaps, which links solutions and a fairly focused approach to community health improvement. And actually, we're spending more now on the roadmaps than we are on the rankings. So let me just conclude then by talking about what we've learned. First of all, we know that we can actually do this. We can collect the data. Our model allows us to summarize the health outcomes and health determinants, and we've managed to get it done. We know that when we rank the counties, and I think ranking turns out to be a very important part. When we did this in Wisconsin the first year, we actually used the consumer reports, open circles and partial circles, and it bombed. That report, I didn't allow copies to leave the room where we presented it because nobody understood it. We took it back. This was in the fall of 2002, and in January of 2003, we ranked. And the media jumped on it and said, well, now I can have a story. These are the healthiest and least healthy places in the state of Wisconsin. So although I don't know for sure what ranking does, that was a little quasi-experiment which showed to me that ranking gets people's attention. The media, local health officers, but also physicians and others in the community. We do see community engagement. I think there's the potential for an integrator to come in and think about using this model of broad population health determinants. We know if these integrators or these community engaged folks used evidence-based programs and policies, we'd improve health outcomes. My last point is that we really need to do a lot more work in understanding, once you get people together and engaged, how do we know, what can we do to then move these people who are sitting at the table towards evidence-based programs and policies? Where are the resources? How do public health, traditionally governmental public health stakeholders work with folks in healthcare? So this is really more of our work now is focused on the actual process of engagement and less on the delivery of the county health rankings. So that's. Do you want to do comments after?
Let's take all of the panel. Is that what first of all? Where's my coat? Okay, thanks. Let's take them all. And then we'll open it for questions.
Let's see, how do I do this? Just pressing maybe? Thank you for having me. Thank you for the introduction. It's been a fabulously timely and valuable discussion. Even if we just talked this morning, just what went on this morning I thought was really stimulating work and promising work. I feel privileged being here. I feel a little bit under the gun given that so many smart people are in the room and so much has already been said. The window of contribution seems to be narrowing, so I'm thankful to Carole to take the last seat, and I know she will be fine because she has things to say. So what I was asked to do is talk about measurement context, talk about measurement from a health policy perspective, and I want to do that by talking about context, providing some examples, and talk about challenges and lessons. But before I get into the context, I have to share with you that whenever I'm a state employee, whenever I leave state of Minnesota, I'm required to make a reference to the Prairie Home Companion. So, a show of hands, who's familiar, Garrison Keillor, Prairie Home Companion? So, for context, I would say, in Minnesota, our data is strong. our stakeholders are good looking, and our appetite for health reform is above average. So unless you think I was so clever to come up with this myself, I actually stole that idea from my commissioner. So I think we're in a good place in Minnesota in measurement, but also in continuing to sort of break paths in health reform as we move forward. Sort of the context in which this has been embedded is that we have a legislature that sort of has an experience with conducting health reform and with seeking empirical evidence to inform that process. It's not always the case, it's not on all topics, but generally speaking, that's been going on. So much so that there is sort of a recognition and funding to conduct research and monitoring population-wide on things like access, utilization, quality, and healthcare costs. We also have a very dynamic and innovative private sector, and some of the finest representatives are here, of course, who have sort of put us in the lead on concepts like managed care and utilization management and measurement in general, and now sort of moving into this new scary world of shared savings. Arguably the largely nonprofit sector, both on the plan and the hospital side, probably has contributed to a collaborative environment that has given rise to organizations like ICSI and Community Measurement. Again, two organizations who are represented here, who really helped us understand what works in the healthcare system, what doesn't work, and how do we improve what we know. There are also some more recent dynamics that are of interest and that sort of lay out the land perhaps for the future. Tons of commission, tons of governors' initiatives. In 2008, we passed really fairly path-breaking bipartisan health reform that preceded the ACA in many ways, both in concept and in some ideas. I'll touch on three things really at a high level because I don't want to use up too much time, but making investment in public health through our statewide health improvement initiatives, giving grants to affect obesity and tobacco use, really investing in healthcare homes to enhance patient experience and create more patient-centeredness in care, and then really to place a big focus on cost trends through improvement in transparency and cost and quality, and payment reform, sort of particular from the Medicaid payer perspective. Currently, we have in operations and nearly finalizing the work is the Governor Dayton's Healthcare Reform Task Force. Somebody said roadmap. We all use this term these days, aren't we? They are developing a roadmap for reform, for implementation the next few years, and they're looking at workforce. We're looking at access. We're looking at integration and payment reform. And the fourth is public health and population health. That's going to be sort of hopefully reinvigorating where we're going. So where are we with regard to the status quo of measurement in the state? None of this is particularly new and exciting, but we do research and analysis and measurement by looking at collecting primary data and analyzing secondary data, sort of in these various domains. And I'll have a few examples for you to show you, because you are decidedly a self-professed geeky audience. So, again, not particularly new, but really a story that resonates with policymakers and with the media. Our trend of healthcare costs is really unsustainable, just moving much faster than other indicators in the state. Similarly, we estimate healthcare spending on an annual basis, sort of doing our own analysis of spending, using sort of national models for estimating healthcare spending, but our own data and our own approach, and projecting spending 10 years out. And not very surprisingly, we find that if we don't do anything, healthcare spending will double in the state. And this is total healthcare spending that includes, veterans and, railroad and public health. And we also, this is an example of sort of measuring year after year and displaying year after year sort of the shameful disparities in race and ethnicity on a whole bunch of indicators. So we measure away. All of this so far has been fairly high level, fairly fairly aggregated data. Getting a little bit more disaggregated as we look at cost and quality. This is an example of work that is based really on the intellectual capacity and the initiative that's come out of the private sector to measure quality of care in clinics on a whole set of measures, and hospitals and ambulatory surgery centers or in outpatient surgery settings. And this is a nice example of public-private partnership as we enjoy it in Minnesota, where the initiative and the idea really started out in the private sector. Voluntarily, data were reported. Then during health reform, the M word, M as in mandate, helped to scale this up, create really equity in reporting, and a greater ability to bring really everyone to the table, not just the ones who are confident about the quality of care that they voluntarily participate. Again, I don't want to say much about the data other than there's room for improvement, and even though we've seen some improvement over time. And that by itself, of course, is a great outcome of measurement. This is perhaps the most disaggregated that we might be able to get if when we're able to get there. As part of the 2008 health reform law, we're directed to develop, well, initially it was a value, a single measure of value of relative provider value in the state, and through sort of a group process that I think was helpful, although it was definitely a struggle. We sort of agreed to look at quality and cost as two dimensions that we don't want to roll up because people have different perspectives on what they value and how they weight these individual pieces. So this is work that is in the development process. We're starting with confidentially reporting this to providers and then eventually publicly reporting. So as we talked in the cost work group yesterday, this is what we do at a very high level, but the drill down is where the value then is of this kind of work. But we are in a changing environment, so much so that the word cloud of organizations and initiatives that are sort of operating in health reform and are trying to transform the delivery system and how we use resources in healthcare reform. It's getting really crowded here. So what may be hard to find are things like the CMMI grant that we have applied for, and I hope you all keep your fingers crossed for us for a December announcement. The state has decided to implement a state-based health insurance exchange. We have Medicare ACOs, Medicaid ACOs. The provider sector is innovating left and right on a whole range of issues. So what does that mean about measurement? Well, it scales things up quite dramatically, at least potentially it does. Sort of creating new areas for measurement, like affordability, for instance, in the exchange, thinking about provider innovation, thinking about population health as well. So the room for understanding our healthcare system and evaluating it and making sure that we are on the right track or we can adjust what we do sort of it will be expanding just massively with these various initiatives moving forward. So challenges and lessons. We've talked about this yesterday a ton, so I don't know that there's a lot of original thinking in here. But I'll focus on a couple of topics perhaps that may be of value in the ongoing discussion around a core measurement set. Establishing clarity about purpose for developing measures or for a measurement set. We've talked about it just this morning. I thought it was a really important discussion to say, know what you're trying to develop a measurement set for, and don't try to have one set that accomplishes everything from regulation to evaluation to public reporting. So I think we need to be mindful about the purpose of measurement, and we need to resist sort of trying to design the perfect. Aligning measures, everyone has talked about it. The tsunami, the whatever analogy you want to use, is upon us already. We're not awaiting this. We're experiencing it. We need to do work. We're really excited, the work that ONC is doing in partnership with CMS and others. We're moving in the right direction, but we can't move towards creating better measures that get us closer to evaluating provider quality unless we sort of take out some of the unnecessary measures or some of the duplication in measures. Some of the most innovative providers in the state track as much as 1,000 measures, and that's just plain crazy. So alignment both with the federal government, with other payers, is going to be important. We have passed, as part of health reform legislation, we've passed sort of the quality measurement set for Minnesota that's thought of as a core set, an evolving set. But I think we need to be disciplined in how we apply that in the state as well. So there can hardly ever be a reason for MDH to track different quality measures than the Department of Health, than the Department of Human Services. So we need to continue alignment there. We need to figure out sort of how to deal with how to resolve the tension between speeding up measurement, but still doing it so that we get to better measures, while still incorporating community input and community priorities in the process. I don't know how we resolve that. I think both are important, but maybe this group has great ideas. We've talked about public health and population health, and to provoke Kevin a little bit, maybe I would toss health IT in here as well to say we sort of have a very strong sense that there are opportunities in leveraging resources differently and taking advantage of developments in these areas. But it feels that for policymakers, the business case hasn't been proven. So I think we need to do more work. There's a ton in the pipeline, and that's exciting, but more work is necessary. If you go back to this slide, the danger is that we just go measurement crazy and everyone, the exchange measures here and the human services measures there, and our department measures on population health and markets there. So we need to figure out a way of coordinating what we do and how we report this information in order to be of value. Otherwise, we just measure and confuse people. And speaking of confusing legislators, and I'm not saying they're easily confused, but legislators look for something plain, straightforward, actionable, and composites and indexes is what they're saying, what they're looking for. They want a few measures where they can say, have we improved where we were last year or not, or 3 years ago or not, or how do we compare with other states? Are we the healthiest state? So, and I am wrapping up. The challenge there is whatever measures we create for policymakers, they have to be related to what we're implementing, because otherwise we're holding ourselves to standards that we can't meet. And in terms of meaningfulness, I think, and this is my last slide, we really need to figure out what it is consumers need and what they value and what they expect from healthcare and how they want to track whether health for them personally has changed over time. And this is sort of one example of work done in Minnesota where we sort of, where the Bush Foundation brought together folks to engage on that topic. And if you have time, you should look at that video. It's fun to make an argument through cartoons on why health reform is necessary. And if you still haven't had enough, here are a couple of links to look at more information. Thank you. And I'm sorry I went a little over.
That's fine. It was very helpful. Thank you very much. And as Carole is approaching the podium, I would ask Rob, I meant to ask you this yesterday, will the slides that have been presented throughout this conference be available to all of us? To get permission to share them. There's so much rich information that I would love to have access to as much as people are willing to share to take home. So thank you for that. Carole.
Good morning. Thank you for giving me this time to share what we're doing in Oregon, way out in Oregon. I want to focus specifically today on the context that we're working with in Oregon and our experience and the process of implementing the triple aim and using metrics to measure our progress there. It started with a budget crisis, basically, and I think I could have used Stefan's slide of the cost of healthcare going up so much faster than inflation, and in particular in Oregon, we focused in on Medicaid because it is the fastest growing portion of the state budget. It accounts for 11% of the state budget. 50% of all births in Oregon are paid for by Medicaid. 16% or 1 in 6 Oregonians are on Medicaid, and 85% of providers in Oregon participate in Medicaid. And so we thought this is a critical sector of the economy, and this is, we are lucky to have a governor, Dr. John Kitzhaber, who is visionary in terms of health policy, and he said, look, we've got to change this. It's about the state health and well-being. It's about our schools. It's about our roads. And we need to start with Medicaid, but we do have our eye on all the health care that the state purchases for its own employees and retirees, et cetera. So we're starting with Medicaid, but everyone's on notice that more to come. So we contacted our partner, CMS, and said, here's what we want to do. We want to enact the triple aim. And we made sort of a commitment to them that we would lower the cost curve by 2 percentage points. So where the president's budget finds that cost is increasing at 5.4%, we said that at the end of our 5-year demonstration, we would bring that down to 3.4%. But that while doing so, we would not compromise the health of the population or degrade health care in any way. So, and I want to say that we're about to complete our waiver. Andy Hackbarth is smiling over there because Andy has been participating in the negotiations that have been going on since the spring between CMS and Oregon, because I think we are also a little laboratory for how to make this work nationally. So what we do in Oregon, even though we're a really small state, I think could have impact beyond our borders. So CMS has devoted a lot of time and energy and have been really great partners. I want to thank Andy for his help in particular. So we should be able to wrap that up by tomorrow. So I've been afraid to look at my email this morning to see exactly how that's going. But in order to make the triple aim happen, we recognize that we actually have to change the way we deliver care drastically. And we created some building blocks in our concept. And we start with what we're calling coordinated care organizations, or CCOs, and they're directly analogous to the ACOs on the national level. And those CCOs are responsible for all the care, not just the physical health care, but the mental health care, the oral care. We really want to see a coordinated and integrated model in each community, one that would have a global budget and be responsible for the health and well-being of the people in their catchment area. We intend to use metrics to monitor our progress, and also have a perspective that all healthcare is local, and that the responsibility for this lays at the local level, and that these CCOs are mandated to work with the community partners outside of the healthcare system. So, and we also offer them a lot of flexibility in how they deliver the care. So we're saying, here's the money, here are the outcomes, go forth. So we've had to build in a number of levers to make sure that, from our point of view, the right incentives are there. One of them I would call out is the alternative payment methodologies. So we really expect that to occur at the provider level. For the state, what we're starting with is moving from a model of capitation to pay for performance. And the way that we're doing that is we're starting with a quality pool, an incentive that is part of the capitation. And I'll talk a little bit more about that in a few slides. But we hope to see an increasing portion of the capitation be devoted to this incentive, and a decreasing portion based on just the widgets that are produced, which is basically what the actuarial model is. So one of the key aspects of this health system transformation, as we call it, is that we need to also provide supports. You know, you can set out the requirements, but you also have to make sure that it can happen realistically. And one of the ideas that we're putting into place is what we're calling a transformation center, and also the innovator agents who are kind of part of this transformation center. So for the innovator agents, people may have read the Atul Gawande article about the model of the agricultural department and the extension service. It's that kind of idea. These folks are employees of the state, but are outstationed or, you know, somehow, you know, not embedded, I'm sorry. They're assigned to a particular CCO, and at that CCO, they provide the function of being a bureaucracy buster with us at the state, but also working with the CCO to understand what are the issues, what are the problems that are coming up and for implementation, and then going back to the transformation center and saying, this is what we need to build. We need to build learning collaboratives around the primary care home. We actually call it the patient-centered primary care home in Oregon to reflect our belief that non-traditional healthcare workers, as we call them, or community health workers, are an essential part of the healthcare team. We're really looking to healthcare teams to be built. And we're supporting the growth of these workers by setting out the criteria for certification and also working with the community colleges to set up training programs. So the metrics. we're big believers in stakeholder groups in Oregon, and I participated on one that developed this list of criteria or principles for the development of metrics, and you probably have similar lists in your own states, but they become critically important when people realize that they are being tied to reimbursement. So if you have financial incentives, you really have to get those metrics straight. So overall, we have more than 80 metrics that we're tracking, and one of the stimulants, as we call it, to the kind of transformation that we hope to see is that these will all be published on our website by CCO. So there is a lot of transparency built into it. We initially set out a set of what we're calling core CCO performance metrics. That stakeholder group that I participated in developed the original list. It's in their contracts, and that's got 22 measures, all of them parsed by ethnic and racial components. I'm going to move a little more quickly, but we are working with CMS to test the CHIPRA and adult core measures, and so they're part of what we're also tracking. I want to just talk briefly about the quality pool. This is the incentive that I talked about earlier in our trajectory towards pay for performance, and we again use a stakeholder group to come up with the list. They completed it just recently, and we have 17 measures. We're still working with CMS on fine-tuning. I keep getting requests, where's the final list? But by Friday, we should know that. And we had a number of domains that we felt that we needed to cover. We feel that behavioral health integration is key to the promotion of health and to creation of healthy communities in the Medicaid situation. Maternal child health is also important. Chronic diseases, access, the patient experience of care. You probably all have lists. We've been talking about lists, but we try to get a manageable group. We also have legislators who say 3 measures. We want to see 3 measures. And so in talking about, sorry, there we go. In talking about the challenges, I would say that we've all talked here a lot about alignment. We have been thinking in Oregon about aligning with the groups in Oregon that, like the exchange. So we want our providers and our health plans to not be going crazy with multiple lists. That gets to the issue of parsimony, always an issue. I don't think 80 measures are parsimonious. I think parsimony is important because people need to be able to focus in on something doable, and the more you have, you could have people just throwing up their hands, but this is no news to anyone here. Just want to mention some key learnings that I'd like to share. One is that as you can see from the discussion that I just engaged in with you, metrics are only part of the equation. They're important, but if you don't have the triple aim behind you, you're really not going to get that far. We believe in stakeholder involvement in Oregon, and yes, it's messy, yes, it's difficult, but at the end of the day, people feel like they really participated, and then you find that champions emerge, and that people support the process a lot more than if they felt that it was imposed on them in a mandate. And then finally, just aligning around a model. I think that's the key thing, that everybody knows this is where we're going and this is why. So if you want more details on the specifics, go to our website. It'll all be up there after Friday.
Thank you so much, Carole. Excellent. These are really excellent presentations, and we are at our 10:15, but I was given a few extra minutes. We'll split a little bit and spend a few minutes to get comments. I was struck by the comments about changing from the consumer reports to a ranking, a number. We are all so competitive, and I sat here listening to all these wonderful things from Wisconsin and Minnesota and Oregon, and wished I'd talked more about California in the few minutes that I took at the beginning. We are competitive by nature, and I think that that's what makes metrics so important, because as so many have said here, we have to drive what the change is that we want to see, and a lot of that is driven, and certainly, as has often been said, what you measure matters, and this is a really stimulating conversation. Thank you all very much. Yes, sir.
Thanks. Thank you all for, these are three very, very impressive programs. I wanted, this is a question for Pat. A theme in this conference has been parsimony, or even embarrassing parsimony. And I recognize the need for that and the daunting challenge of producing these metrics for 3,000 counties around the country. There's one relationship that I would ask about, though, that's left out that I think is important, and maybe even important to the core metrics discussion for population health. That's the relationship between external risk factors and internal risk factors. We know that we can entreat people to stop smoking, exercise more, and eat healthier, but without addressing the social and physical environmental factors that create those circumstances, we'll probably lose that battle. And, you know, I'm not exactly sure how to do it, but when you even do the percentage allocation of those contributions, they're related to each other. Maybe an arrow, but also perhaps to the point of this conference, when we, in the population health measurement, when we talk about if we frame it as internal and external factors affecting risk, we really need to draw a relationship between the two.
Thank you.
So I would just agree with that. When someone told me yesterday they looked at the scatter plot between social and economic factors and health outcomes, and it's highly correlated. About 60% of the variance is explained, but then you can control for behaviors and quality of health care, and that variance reduces. But there are arrows, obviously, connecting. A healthy, robust social and economic foundation helps the healthcare system, helps with health behaviors and urban design even. So it's all interconnected.
Well, that was really the point I wanted to make too, Leslie Mickelson, Prevention Institute. And let me just, and I'd like to open it up to the whole panel, because I think this is important. There's a difference between looking at those behaviors as outcomes, which it makes sense. Those are the outcomes we want to reach. But how much do we build into the model the items that will help us get to the change? And one thing I realized is we're setting up a difficulty for the health systems, right? Because we know that they're not going to be able to really move the needle on those health behaviors. That's been proven again and again. So I think it just made me want to go back to our thinking about the population health model. And I just love to hear people comment on it. But just to take Matt's point, I think it's not just social and economic factors. It's tobacco policy related to taxes, related to limiting smoking, related to work site, or with, I work a lot on food and activity, you know, it's land use and transportation policy. So I just love to hear some commentary on thinking, yeah, how do we build that, make that a little more visible without ending up with, I know CDC has 25 factors related to food and activity that are community environmental variables. So love to hear some thinking.
I'd like to start with the Let's Get Healthy task force that we've just done, and the challenge that we had to keep from trying to link interventions to the metrics. And that seems counterintuitive, because when you see the measure, then you want to see what you have to do to meet the measure. And our approach was set the goal and set what you're going to measure, and then let 1,000 flowers bloom. Let every part of the system, wherever it is, do whatever they think is necessary to get to that, and periodically measure, so that we're saying, are we moving those lines, and we won't be able to go back and thank everybody for the very specific thing they did that moved those lines, but we think we're not going to move those lines unless everybody's working. And I also chair the Health Exchange, and we're working there. I lead the public health department is in my agency. We have a Health and All Policies that is working with the Strategic Growth Council. We're working with local communities in their housing elements and their transportation elements and all of those things. And if I tried as secretary to manage all of that and direct it toward these aims, it would be an impossible task. So my reaction to it is to keep the triple aim. Its beauty is its simplicity, and it means something to everyone who interprets it. And we've got to try to make sure that we're integrating our policies in the silos that they represent, because as much as we try, we won't eliminate all the silos. That's my response.
Maybe a question or maybe a reaction to what you said, Diane. I don't know if this is on. You know, is it a surprise that we have been trying to get at the issue of disparities, of health disparities, in all kinds of ways, with a lot of resources spent, but with very little success, given that we sort of kept that intervention in the health budget, in health care? So the conversation that we yesterday had on healthcare cost was we sort of put public health aside because we said, well, it's too complicated. If you throw that in, then you get into education and you get into all kinds of other things. But what if we need to get into all kinds of other things?
Well, I do think we do, and we have included indicators like reading rates at third grade and community. There are a number of other of this, what we call social determinants of health that are in our indicators that we will measure, but what we've tried not to do is tie them specifically to a particular intervention. I think that's where we would get in trouble.
I think my question is probably a variation on the previous two. Pat, you ended your talk, which was just beautiful. In fact, all three of you, this has just been fabulous eye-opener in a number of ways. You ended it with the last little box that said community engagement, and your quick reference that now you're starting to put more time into that than in the earlier work. And so I guess I'm really, can you offer anything specific about what you're doing or want to do in community engagement that obviously is probably going to get to some of these difficult conundrums? But I'd love your thoughts about that, and also Stefan and Carole, whether there's anything you have to contribute to. What can an organization like yours actually do if the government hasn't given you $6 trillion to do it?
Well, we'll ask Robert Wood Johnson for that budget. No, so I think the measures drive response. And we've seen communities, in fact, maybe people here come from some communities where there's been lots of mobilization in response to this issue. So I think, though, I probably can predict what George is going to say, that this is a call to action. It's not the roadmap. We're starting those discussions, but what I find is the roadmap varies depending on where you are, whether you're a county in Mississippi or Wyandotte County in Kansas. People really respond much differently. I agree entirely with Diana. The reason that orange box is in the lower left-hand corner, that's to be determined, and it is so variable. I'm not sure I could come up with the right interventions or even the right format or governance structure for a convening organization. Sometimes it's the mayor's office, sometimes it's a CEO of a health system, sometimes it's a real strong local public health agency director. So what we keep doing is pointing out the problem. The other thing is I think our county health rankings is a disparity measure. We don't have disparity measures within county. We'd like to. That would be great. Actually, we've tried a few and nobody's even mentioned them. But I think as a state health officer, Diana can look at the counties within the state, and there's tremendous disparity across states. So I would imagine most health systems cross county borders. What are you doing about the disparities in the health referral region or in the state? In our state, the differences are dramatic. We have more variability within state than across the country. between our healthiest and least healthy counties. What I've been curious about is relatively little discussion at our state office about that variability. Simply, counties seem to be addressing their issues from within, but I think someday the disparity needs to be addressed, not just across states, but within states. It's really dramatic that you cross a boundary in our state from an urban to suburban community, or even well-to-do rural communities. The next community right next door is very poor, very impoverished, and really horrible health outcomes.
Carole.
Yes, well, this is a great question, and we really did in Oregon consider this question and tried to build in to our model some features that we hope will get there. So the CCOs, the Coordinated Care Organizations, are required by contract to have a community advisory council. They're also required to do a community health needs assessment, and then we've supported them, or plan to support them, with our public health department and also our Office of Equity and Inclusion. So we've got both from the resource side and from the requirement side some specific interventions on this. Time will tell if it's going to work.
And I completely agree with Carole, and I think, Marge, I would circle back to the comments about stakeholder engagement, because I think the decisions that are most likely to be implemented are the ones that people think they made themselves. And the more likely you are to engage them, the more likely you are. None of our laws ever work without self-enforcement, and so people have to believe that what they're doing is the right thing to do, and it really compels the very messy work. I can tell you how many times I wanted to do what Patrick did and just get in a room and say, okay, these are the measures we're going to use on our Let's Get Healthy task force. But I now have an army of people who are invested in this process, and we'll go out and try to make it happen. Stefan, and then we need to move through the next question.
Yeah, just a quick comment. I mean, in Minnesota, we aren't quite like Oregon. So, but community engagement is playing a bigger role, and it's a tricky thing, because when you engage, you sort of actually have to listen.
That's right.
But you know, I think what we've learned from this process that I sort of highlighted, touched on, is that consumers, patients are actually probably more interested in playing a role. Sort of one quote that I meant to share with you was that people said, empower Minnesotans to be co-creators and co-managers of their health. So I think that's a very action-oriented commitment, recognizing that there are limitations to what the system can do for you. So I think bringing, allowing governance through consumer engagement, listening to consumers, holding them accountable is probably one way to let these various flowers bloom, as you've said.
Thank you. George.
Yeah, thanks for this panel. A really terrific set of presentations and comments. Pat, thank you for the secret slide. You know, I'm trying to now imagine the slides I've seen for cost by state, which I've seen those, and the quality of care slides by state from some of the Commonwealth Fund, and trying to sort of, you know, personally integrate a triple aim picture of the country. I'm not so sure I can do that mentally, but that's the thing that comes to mind. And I am a tremendous fan of the Wisconsin project and your work and David's work. But the approach you've taken obscures the national policy issue about how we deal, you know, approach regions of the country where there's not just a few counties, but just systematically large areas that are different in performance, and how we approach, you know, bringing the country to less skew in terms of distribution of health across the country. I think that there's times long overdue for a lot more attention to that issue, and for a serious discussion, regional discussions, constitutional convention kind of discussions or whatever, in terms of really trying to think through that issue to guide national and state and local policy. Because I do think it's important for the federal government to have policies. I do think it's important, as you are doing and very effectively, to engage communities and so forth. But I think there's that issue that's missing in the mix. Stefan, thanks so much. I mean, we've been blessed in Minnesota with a strong Department of Health, really appreciate your project. I'd point to your cost slide. Although we're innovative in Minnesota in many ways, and we developed this cost measure, and we can show we can move it by organization, we still have an overall cost problem that we're not touching. And we also have identified waste and are engaging specialties in terms of the choosing wisely kind of approach. But the cost solution requires bigger thinking as well as thinking at those other levels. And I just point out that cost problem is a multi-layered problem. It won't be solved by a single indicator or a single approach. And some of the bigger issues, we have to jointly sort of figure out. Thank you for your presentation. And then the last comment is that several of folks here in this panel and actually in other presentations have sort of almost reflexly talked about the fact that if you have hundreds or thousands of measures in an organization, that's wrong. Implied parsimony is the ultimate objective and so forth. I heard that mentioned. I think exactly the opposite. There's a paradox there, that when you're trying to have requirements for individual providers from multiple organizations or purposes, you do need parsimony, and when you're trying to think of the key rules to move the complex system forward, you need just a few things. But when you're trying to improve care across an organization with a number of things, you need to use information and use it more robustly than we have traditionally to move care. And that's manifest by the multiplication of the uses of measures. And we actually need to have a capacity to deal with that as organizations because I think that's going to be a capability for effectiveness going forward. So there's a paradox there. And I hate to see that reflex sort of discussion of that, come out as some sort of general rule, because it's also a political sort of thing with respect to those in the care system who are not yet interested in being engaged in measurement and trying to push back by pushing the parsimony kind of issue as well. So that's a complex issue. Fit for purpose, I've learned from my co-chair at the MAP, Beth McGlynn, is a really important reason to use the tool of measurement to advance policy. And parsimony comes down the road from that.
Thank you, George.
Well, that's great, because actually, as I was sitting through the presentations today, I was struggling with the same issue that George Isham just brought up. One potential approach, and I won't make believe I have all the answers, but what I've done in systems of reporting data to physicians is to create a tree structure. So the core measures we've been talking about now form the top level, and they're almost like a dashboard. But then and we talked a little bit about this on the cost group, you can drill down in different ways, and if this dashboard light is red, that means you better go down this pathway, and that's where you get the connection between the dashboard down to the actionable information. So is it your quality or cost? If it's quality, which diseases? If it's diabetes, which measures within diabetes? And if it's measure X, which patients? So that's been very successful in some of the programs I've done.
You can stay in line, but we've just...
I'm sorry.
Be brief.
So it would be good to have a further discussion maybe during the implementation. I do have one question, though, for Carole Romm. I love the idea, and I think it's critical that we integrate behavioral and medical and physical care. And I just was wondering about the practical aspects. You can imagine reports on separate measures all the way through to embedding a psychologist in practice. So I was just wondering your thoughts about how you might actually integrate those two aspects of care.
I want to hear the answer, Carole, but could maybe we take that into the break and have the conversation on the side? We've caught up a little bit, but we're really quite far behind in the schedule. If we could collect those, and thank you.
Thank you. I just wanted to clarify my earlier point. I didn't mean to take the mic off, which is just, I totally agree that it's not a one-size-fits-all solution. I do think it's important to remember, and someone who's worked on obesity prevention for over a decade now, that you can't take it for granted that when the public sees a health risk behavior, that they understand that the solution is these community changes. So I just think it's important to have a marker in there that really somehow shows that there's a relationship between community environments and these health behaviors.
Thank you.
Diana, I just wanted to say, in moving these large metrics into action, I've had the opposite experience that you have, so I just wanted to tell you that, is in addition to what George said about having other measures that might help you on the ground, people actually want to know what are some of the key activities they could start on, you know, and don't want to go and reinvent, you know, do all kinds of thousands of flowers.
Don't get me wrong, we have a whole list included and encouraging interventions, but tying what actually results in the movement is what we were trying to avoid.
Thank you.
Thank you.
I'll just make 2 quick comments. I am the Commonwealth Fund scorecards, by the way. You know, not just me, but we're going to be doing a new one this year, hopefully by the middle of the year, and we're going to use your years of potential life lost as an indicator, but we're looking at vulnerable populations, just low income. And when you look across the state maps, which George's point of let's look across the states, most of the variation is in the vulnerable population. It's explaining a lot of our state averages. We've seen very little in the high-income population, and we've done years of potential life loss by education. So we've truncated it. It's in the less educated, but huge variations across the state by that group. So it's not just you're at risk, you're a lot more risk depending on where you live. So I think it's really important to be thinking equity and what's pulling down an average. And then in Oregon, I have a question, and we can do more in the break, but you're starting mainly with Medicaid, as I understand it, although there is an aspiration of bringing in the public employees. And when you're doing a geographic transformation and thinking of global and thinking of interventions, you're going to have to change the whole system if you're really doing that. So is there a timetable for bringing in the public employees or bringing in the Medicare population so that we don't do these slices by income as much as by whole geographic areas?
And I'll let Carole have the last word.
Okay. I need to get back to you on the specific timeline, but the idea is to make it, to get it up and running in Medicaid first. The next group is the public employees, and they've been part of this process. So it's not like we're just, you know, starting here and forgetting about you until next year. So they've been, and we've been thinking all along about how it would work with that population, which is, as you point out, different. I do want to say that the changes are dramatic and have created quite an upheaval. Leah Christensen from Oregon is back there, can confirm. I mean, we have seen in the Portland region the three biggest insurers who are usually at their each other's throats working together, come together to form a CCO. I mean, that in itself is something that I would never have imagined in the 30 years that I've worked in healthcare, that they could sit down and form one organization. So there's hope.
I think that's an excellent place to stop. Thank you so much, Carole. A 10-minute break.
Well, they're prevented, they can't be sued.
Yes.
Where did I, oh, is that you? I was going to say, where did I leave my computer?
Oh, you're welcome. Oh, you're welcome. I'm very glad to meet you.
Yeah, it's in the law, you know, you're allowed to do this, you know, but they formed a new organization. Hi.
structure. I think when we first started designing this session in the planning committee, I think during the last 2 days, the notion of what infrastructure is clearly gotten richer and broader. When I think about the 2 days, we've talked about the integrator idea. We've talked about creating conditions for complex systems. We've talked about leadership, engaged communities, and governance, about alignment, payment, and policy, and and many things around practice transformation that include collaboration with public health and integration of behavioral mental health. A number of issues around what I would call health system vitality, the coordination and collaboration among the public and private sector, leveraging local capacity, and then in terms of improving healthcare delivery, around shared performance measures, about learning systems. We have used the word learning systems and transparency, IT capacity, connectivity, and support. And so all of these issues, and there are probably some other ones that have come up the last 2 days, do inform our discussion around infrastructure. So we are lucky today to have 3 speakers who are going to kick off in 10 or 12 minutes or whatever it is, some thoughts to stimulate our discussion. I'm just going to introduce people now so we can just keep going and not lose our train of thought. Is Kevin Larsen, and Kevin is the medical director of meaningful use for the national coordinator, the Office of the National Coordinator, IT. He's the medical director there. He's totally responsible, I guess, for coordinating all these clinical quality measures for meaningful use certification, and also overseeing the development of population health tool. And before he came to work for the federal government, no surprise, a native of Minnesota, he was chief medical informatics officer at the Hennepin County Medical Center, and has done research around healthcare financing for people living in poverty, and also computer systems that help support clinical decision making. Christopher Queram is president and CEO of the Wisconsin Collaborative for Healthcare Quality, and over the last 7 or 8 years, Chris has been president and CEO of the Wisconsin Collaborative for Healthcare Quality, which is a voluntary consortium of organizations working to improve healthcare quality, affordability, and the health of the people of Wisconsin. And as this collaborative has done such things that some of the things that we've heard in terms of public reporting of comparable performance information, collaborative learning systems, and sharing of best practices. And before coming to this position, Chris was CEO of the Employer Health Care Allowance Cooperative in Madison, and also has been a hospital executive. Bruce Ferguson is the chairman of the Department of Cardiovascular Sciences at East Carolina Heart Institute at the East Carolina University over the last, I guess, 5 or 6 years. I first met Bruce when I worked for AHRQ on the Transforming Healthcare Through IT grants when he was in New Orleans, and Bruce did heroic work at Charity Hospital for many years in New Orleans, and he's a board-certified cardiothoracic surgeon who specializes in adult thoracic surgery, and he's also been the chair of the Society of Thoracic Surgeons Council on Quality Research and Patient Safety. So clearly, I think we have a distinguished group of individuals, and why don't we start off, Kevin?
So it was a little bit interesting to figure out how to frame this. I'm going to actually go through a little bit of a background about meaningful use because although many of you know it, I don't know that everyone does, but I'll make that part brief. Let's see, this advances my slides. There we go. So I'd like to really start every one of my slides with we're also in the job of supporting the triple aim. And our job in health IT is to support the work of the people doing the work. Where do I point? There we go. So some discussion about what the vision for the future of measurement is. In our office, in the Office of National Coordinator of Health IT, we think about measures as tools, and they're not just for accountability. They're tools that are really used by providers, by organizations, by public health to do things. And we need to know what it is they want to do with those. When we talk to providers, what they want to do is fix stuff. So measures are there for them to use as a tool so they can drive improvement. And I think that many other parts of the whole measurement and healthcare ecosystem want that same thing. They want to use a tool to know how they improve. So we're working on a strategy of measurement that is about real-time measurement as opposed to what often happens now, which is retrospective measurement. How can we know nearly instantly what has happened, what care gaps exist, how things should work? Local ownership with some benchmarking, linked to decision support, and then some of the many things that we've also talked about here at this meeting. And maybe a little bit of a story. So Dr. Musashari, the national coordinator, was visiting a hospital when he asked some quality improvement nurses, so what do you think about these IT-enabled measures? And they kind of sheepishly smiled, and they said, we feel like we're cheating. And he said, what do you mean? He said, well, we used to, after a patient was discharged, get their chart and spend hours looking through to find all the care that we had given. And when we found a care gap, we spent more hours looking through the chart some more to say, we knew we did this thing, but now we want to prove it. They said, now we get a report every morning of all the care gaps in our hospital. And we actually go out and talk to the nurses and figure out how we can fix the care so we don't have gaps by the time the patients were discharged from the hospital. So it's a fundamentally different way to think about measurement as a real-time tool. Meaningful use. This is a pumpkin. This is meaningful use of a pumpkin. People ask us a lot about what meaningful use means. And the idea is we don't just put in technology for the sake of technology. We put in technology because it supports some goal or purpose. So what is ONC's role in this? This is a driver, and she is new to driving a car. She needs to trust that that car actually works. She needs to trust that the brakes work. She needs to trust that the steering works. She needs to trust that everything actually works. That's the role that ONC is with certification of electronic health records. We are there to help make sure that as a driver of that electronic health record system, you can trust that it's working. So much like someone's doing this non-glamorous work of testing your vehicle to make sure that the emissions and everything else works, that's what we do for EHRs. EHRs can do lots more. So if people want to do more than what our certification program is, we're happy if they do more. But our certification program tests the basics. It tests the brakes, it tests the lights, it tests that things work. We post who's certified here, so as people purchase and use certified electronic health records, they meet the standards that we've asked them to meet. And the vision is that these get adopted widely across the country, and that's happening. We have a lot of tools to help make that happen. So part of this infrastructure is just getting the technology out into the country and making sure that that technology has a set of basic functions and standards that work for the people that decide to use it. Meaningful use is in stages and steps. And so here, stage one, meaningful use, was actually really setting the stage, getting some of the initial infrastructure in place. Stage two is really hope, which just came out, the rules for that just came out, is around advancing clinical processes. Stage three, we're aiming to help support the new models of care, ACOs, patient-centered medical homes, other kinds of new care delivery. So we intentionally use our policy programs in this trajectory of future-driven goals. Now to reporting. There is also a vision, and this is a vision that CMS, who's our partner in this, articulates quite a bit, which is a movement from a landscape of program-specific measures with program-specific reporting systems to a measure once reporting system, report once with a single reporting infrastructure, and then use electronic health record reporting to decrease the transaction cost and collection costs of all that measurement, so that again the investment is in the improvement, The investment isn't in legions of people pouring through charts, spending lots and lots of money to actually collect measurement data. One of my friends runs the quality and reporting for ACO, and they estimated it was $200,000 per year per measure for their data collection for the measures for their ACO. One of the challenges is how do we take the current measurement landscape, which is lots of smart people have spent a long time figuring out how to make really good measures, but they were built for a different platform. They were either built for a claims platform or they were built for this manual chart abstraction and paper. And they have this particular kind of way that they work. How do we migrate that into an electronic way? And once we do that, how do we think differently about measurement? And so we think of measurement actually in a continuum of tools and care that I think this could actually also become a circle where the quality measures then feed back and give us research questions. And this whole thing becomes an infrastructure for a learning health system. So the evolution here, I've talked about this a little bit, is from the paper chart into an electronic health record. And then we can give some real-time decision support, which is the visibility to the people at the front lines of, hey, this patient didn't get a mammogram, and they can see that right now, right there. And then ideally, hey, here is the appointment book, the appointment log for mammograms for today. Your patient could get in for that mammogram right now. So it's not just you did something bad, it's information to help you fix it and visibility into that information. The reality of these is that the early stages of the measurement wasn't perfect. We had to figure this out. We had to figure it out on a national scale. We worked really hard to figure it out, and lots of people spent a lot of time and energy. But it was a brand new infrastructure and a brand new investment. So we know that our early measures are not perfect, and that's part of the reason that the policymakers made it a payment for reporting rather than any kind of a payment for performance system. There are issues with duplicate data, with systems not being interconnected. So if we want to measure a care transition, we actually have to have the two systems interconnected to get data about the transition. We know all those things exist, and we're actively working to fix them. So so back to the infrastructure. What are some things that we're doing actively to think about the infrastructure of measurement? And to George Isham's point, when I think about measures, I think there are some big core measures that everyone focuses on. But we also want a system where if people want specific visibility into specific items and tools for local improvement, we want to create the infrastructure for that as well. To do that, we're building modular measures. And by that I mean that we can stand up the definition of diabetes, have that as a public resource. You don't have to rethink that. You don't have to re-research it. We now host it at the National Library of Medicine, the definition of diabetes. You can use that and build your own measure and know it's lined up with the definition of diabetes that's used in a national program. We're building multiple kinds of those modular components and make our measures out of those modular components. Then at the local level, you can innovate, reuse, reconfigure, but know you're still aligned with population definitions and counter definitions and different definitions of how the measures work. We're also helping to move measures to new standards of representation using more rich clinical language like SNOMED, standardized clinical language. But for those of you that are used to claims-based measures, you need to start getting used to some some different kinds of ways that we're going to be expressing disease and relationships between diseases that's actually much, much richer and more sophisticated than what we're used to using ICD-9, for example. We also have learned that the measures that we build have to be thought of like software. We have to build every single limb and arm of them. We have to test those limbs and arms to make sure they work. Current measures, especially the paper-based chart abstraction measures, can utilize a clinician who can make a clinical judgment to say, did this patient receive all the appropriate services? And that there's some judgment built into the way that measure works. For these automated measures, we can't rely on that clinical judgment. So we have to have a more rigorous testing and standardization process for measures than has happened in the past. We're also busy building, and we built that, and we're continuing to build it out. We also have to have some standardized transition formats, and this is something I think people should really pay attention to. This is the way data can flow in a standardized way across the country for the purpose of quality measurement. So the QRDA1 is the Quality Reporting Data Architecture 1, which is patient-level data designed in it's an XML markup format for geeky technology kind of people, but it's a way to put your data in a standardized structure to move it across the web so that everybody is speaking the same language as they move their data across. We're going to certify that all of the electronic health record vendors can submit their data using this format. So if you build a receiving system, you can receive in that same format, and now you don't have to make a new relationship with each and every partner you have. Everybody can be building to the same format and transmit their data. So I mentioned a little bit about this Value Set Authority Center. This is at the National Library of Medicine. This is a repository of these modular components, especially things like definitions of disease, that are hosted now by the National Library of Medicine, maintained by them, and linked through an API, which means that you can quickly and easily download these very directly right into your computers. We also need to help support a quality ecosystem. So this is not just about your local EHR, it is about that, but it's also about the registry or data intermediary, it's about benchmarking, it's about coaching, it's about this interconnected ecosystem that drives quality improvement. It's not just about measurement, and those things need to be interconnected. Here is an example of one of the tools that providers will use or can use for free that lets them see in near real time, how am I doing on this measure? How are things going? This is a free open source tool that connects to all of our data standards. The goal is that this would be minimal burden to implement. And this has already been implemented, for example, in the Maine Health Information Exchange on top of a large set of data for Maine. I'm nearly out of time, so I'll just move quickly. We also are planning to link our standardized measures to standardized tools that could be put into electronic health records like clinical decision support. So let's say we have a measure about cardiovascular risk reduction. If we could link that to data standards that could instantly calculate a Framingham risk score for a patient or a provider, they could then see that and have a conversation about risk right at the point of care. And the measurement is linked to a tool that helps make decisions, and it becomes part of the quality improvement ecosystem. People have been wondering about what does it look like to have linked measures. I thought I would show an example. This is what the HIV community talks about together. I was just at their meeting. This is what they call their cascade. Public health, healthcare providers, state and federal programs all use this exact same treatment cascade when they're discussing and measuring HIV care. And so there are examples of this being done. We're looking for these kinds of examples to figure out how we might build them into electronic health records. And I think I'll leave with this quote. So this is one of my very favorite quotes. I did work in health literacy, and this is a quote from Oliver Wendell Holmes. I wouldn't give a fig for simplicity on this side of complexity, but I'd give my right arm for simplicity on the other side of complexity. I really think that that is how my life in health IT works as well. If you think of an example of this, it's the Google front page screen. It's a white screen with one little line, and you put a search in, and the whole world of information is at your fingertips, and it all just works. And you don't think about how it works, you don't know how it works, but it works and you like it. That's what we're trying to achieve, and that's what we're working for in health IT. Thank you.
Morning, everyone. I'd like to begin by thanking you for hanging in there for this last panel. I'd also like to thank the Planning Committee for giving me the opportunity to be a part of the program overall, but also the opportunity to introduce you to some of the work that we're doing in Wisconsin. The goals that were set forth for my presentation were to talk a little bit about how we have developed access to data from the health systems in our state, how those health systems are integrating our measures and the measurement work that we do into routine care, redesigning care, improving care for their patients, and how we communicate measures in a way that is useful for various audiences. Before I talk, though, about WCHQ, what I wanted to do is put our work in the broader context of what is becoming and has emerged as a mega trend, and that is the development of other organizations like us around the country. Often referred to as regional health improvement organizations, or RIOs, and I know that had a connotation back a number of years ago. It's come back in a slightly different guise. These organizations are characterized by multi-stakeholder composition in terms of their participation, their governance. They have, for the most part, not-for-profit status and tend to be private sector organizations for the most part, although fostering a close and ongoing relationship with public sector organizations. There's a variety of different activities that these groups do. Some focus exclusively on accountability, public reporting of comparative performance measures. Some focus exclusively on performance improvement. Some try to do both. And as all of our work has matured, we're venturing into new areas such as supporting or catalyzing payment reform and efforts to engage consumers in the use of this information that we've been generating. There's probably about 30 to 50 organizations like us around the country. They've been supported by initiatives such as the Robert Wood Johnson Foundation's Aligning Forces for Quality program that's been operating for about 6 or almost 7 years now. Under Secretary Leavitt in the prior administration, the High Value Healthcare Initiative led to the formation of chartered value exchanges. Our friends at ONC have catalyzed similar community work through their Beacon community programs. And in the audience today, there are any number of groups that could give a similar presentation, including Mylea from Oregon, Tom Williams, who was here yesterday from the Integrated Healthcare Association, IHA, as he likes to clarify, not IHI, Randy Siebel from Cleveland, and the folks from Minnesota, both the Institute for Clinical Systems Improvement and Minnesota Community Measurement. So with that very broad context, let me just tell you a little bit about some of the work that we're doing in Wisconsin. Our organization is the WCHQ, the Wisconsin Collaborative for Healthcare Quality. We were founded in 2003, so we're almost 10 years old now. We are completely voluntary. There's no mandate that requires organizations to participate in our work. And one of our challenges is to maintain a distinctive value proposition that keeps organizations engaged with us across time as this work has matured and as it has become more broadly accepted and codified both in federal programs as well as private sector initiatives. We align our work around the triple aim. We did that very explicitly and very consciously several years ago, in part in anticipation of the prominence that the triple aim would take on as the centerpiece of the national quality strategy. We're structured as a membership organization, and again, keeping in mind that we're voluntary, this list is not complete in terms of the health systems or the provider groups in our state, but it is fairly significant in terms of its scope and its impact because of the predominance of multi-specialty group practices in Wisconsin in integrated health systems. And many of the groups here have either been referenced specifically or implicitly. Some of the other presentations that we've heard over the last day and a half. And they range in size from a group as large as Aurora Healthcare, which has over 1,000 physicians, and something on the order of 150 primary care practices across the eastern part of Wisconsin, to a little group like Wildwood Family Clinic, the last group on the lower right of the screen, which is a 5 or 6 person practitioner primary care clinic on the east side of Madison. Our core competencies revolve around these activities. We develop and increasingly are putting more emphasis on the prioritization of measures that are adopted for various activities, accountability being certainly one, but payment reform and consumer engagement being others. In the early days of our work, we dabbled in developing performance measures, in part because when we started measuring delivery system performance, there were not good measures. We had to adapt HEDIS measures to fit a non-enrolled population approach to measurement, but increasingly are putting more of our emphasis on prioritizing measures. We collect and validate measurement data. Talk about that in a little bit. We publicly report measure results. And we do try to catalyze ongoing sharing of best practices through formal as well as informal learning collaboratives that involve our member organizations. I was asked to talk a little bit about how we acquire data, and this slide is a very brief summary of that. We receive data from physician groups in one of two ways. One is a method where the member organizations do internal programming within their administrative and clinical systems with the measure specifications that we use, and generate both the denominators and the numerators for the measures that we report and submit those to us through a secure data portal. We receive de-identified patient-level data from those organizations so that we can do data audits and validation to ensure the integrity and the accuracy of the results, as well as the conformance to the measurement specifications. And roughly half of our 21 now physician groups reporting data use this method. The more exciting and we think efficient way of accomplishing this work is through a repository-based data submission where we receive global files of encounter data, patient data, and patient demographic and clinical data directly from our member organizations on a frequency that's dictated by the groups in terms of how often they wish to refresh that for some of their internal reporting activities. We store that data in a HIPAA-compliant data repository. It's patient-level data, which allows us to do centralized performance measure calculation and generation. This data repository is approved as a CMS registry for PQRS and meaningful use submission. So one of the benefits that we're able to give back to our member organizations is one data submission for those programs, as well as meeting the requirements of WCHQ for our public reporting. And that's, I know, a path that ONC and CMS is on in terms of simplifying data submission for other purposes as well. This is a quick schematic that describes that repository-based data submission tool in a little bit more detail, showing how it's used in support of both PQRS as well as our own reporting. We share this basic functionality with Minnesota Community Measurement, and between our two organizations, we're one of the larger PQRS submitters to CMS on an annual basis. I thought it might be important just to briefly allude to the process that we use for data validation. When we got started, one of the requirements or requests that was made of by the business community was to build a robust data audit and validation mechanism so as to ensure the accuracy and the integrity of the results. We structure it as a board-level committee. It's chaired by a purchaser and has purchaser and consumer weight in terms of its composition. And we do a variety of different audits and validation of the numerators as well as denominators on a less frequent basis, and have a number of triggers. There's random validation activities. We have outlier triggers. When a new member organization joins, we validate both the denominators and the numerators. And when we introduce new measures, we do the same as well. So the next thing I was asked to address, watching the time and moving quickly through this material, is how our member organizations use our data. We know from the fact that we are structured as a membership organization, and because there is such a great emphasis on the accuracy and the actionability of the data, that the WCHQ measures are used by organizations in support of activities such as office practice redesign, dashboards that are constructed for use to guide internal improvement, to structure compensation programs in negotiations with payers and with purchasers. But the example that I thought I'd use here is how UW Health, which is the academic practice group for the UW Medical School, uses our data in support of their office practice redesign. They've gone through a staged approach. They joined WCHQ in 2004, began sharing clinic level reports transparent through the enterprise in 2009, moved to provider level reports transparent just within the department in 2010, and have now progressed to provider level reports that are transparent through their entire enterprise in 2012. This is a depiction of how they use the data in a variety of different contexts, from organization to clinic to provider level detail and reports. These graphs just show how they have arrayed data and track their performance across time. This is for primary care clinics within their system, 23 in number. This is individual practitioner rankings within each of those 23 primary care clinics. This is individual primary care providers arrayed on a run chart or a graph, and this just shows how their performance has improved in the time since they have been participating in WCHQ. We're grateful that an academic medical center finds this data to be accurate enough to be used in support of their activities, and thought it might be illustrative of how our members derive value from the data that we generate. In terms of how we communicate this information to different audiences, this is our core website. It has been in existence since 2004. We know from the web utilization statistics for this particular site that most of the visits to the site are from the provider organizations themselves as a benchmarking tool. It's also used by various public sector and academic organizations. Very little use of this site by consumers. And you can see why that might be the case, given that it's essentially raw data that is arrayable in a variety of different configurations depending on the interest of the user, but it is primarily intended as a benchmarking tool. As a result of that, we have been experimenting, as a number of organizations are around the country, with different approaches to how we might repurpose and repackage that information on a more consumer-oriented website, wisconsinhealthreports.org. We're using narrative storytelling with two characters, one a diagnosed diabetic, the other with hypertension, designed to put our data in the context of a variety of different information that's useful for self-management and for becoming a good and active partner with your practitioner in support of those particular conditions. And then just in terms of a couple of next steps, Minnesota's been at this level for a number of years. We're moving to practice site level. Right now we're reporting data at the group level. We'll be introducing practice site level data in the spring of 2013, which will allow individuals and provider organizations to see a much more granular depiction of performance. A couple of concluding comments, and some of these probably go without saying. It's been our experience, and as we have evolved over time, that there is no substitute for leadership from senior level executives and thought leaders in both the conceptualization of what might be possible through a collaborative approach, but then also managing and evolving that across time. And what we've seen is that from the initial start with a trusted convener who brought disparate groups together to explore this concept, the moral authority for this collaborative leadership transfers from individuals to the organization. And that's certainly been our experience as well as that of others. We spent the first year of our work together just building social capital and agreeing on what it was we were going to try to accomplish. Our first report was probably less significant in terms of its content, but more significant in terms of the fact that we were able to issue it. Political will and commitment of resources is definitely important, but we also wanted to try to make a contribution to the evidence-based literature. That reporting does drive improvement, and being that this is the IOM, it's always a good idea to cite evidence. And we had an article published in Health Affairs this year showing that there is a correlation between our public reporting and improvement. Last comment that I'd make, and this has maybe been a subtext through some of the discussion, but I think one of the things that all of our organizations share, even though we're different in terms of our composition and our market structures, is we're fragile enterprises. And I alluded to the fact that there has been a commoditization of performance measurement in the last decade. It's having the effect of taking away the human and the financial capital that's critical to do this work at a local level. And this scale of justice is weighted because I think this is the reality, that for all of the good intentions and emphasis of these national level activities, it's crowding out the human and financial capital that's critical to support local activities. And thought leaders such as all of you in this room and others who care about the important role of local stakeholders are in a position to help redress and achieve a greater balance so that this important community work can continue. So I'll stop there. Hope I didn't go too far over time and save time for the rest.
So Kevin quoted Oliver Wendell Holmes, and I will quote Monty Python and say, and now for something entirely different. I would also like to thank Craig and the organizing committee and the Institute of Medicine for the opportunity to be here today. And what I'd like to do is actually build on Chris's comments and Kevin's comments and give you some perspective of a practitioner, somebody with years of experience in the clinical data world and environment, and somebody that may be able to bring some specialty observations to this extraordinarily rich discussion that we've had so far today in anticipation of further developments and work down the road. Much of this is a result of activity that David Stevens was the project officer for our THQIT ARC grant, as you'll see in a couple minutes. Perspective, locale, clinical financial data analyses, real-world obstacles, and technology opportunities. Kevin mentioned this briefly at our breakout session yesterday. David published this paper this month in Health Affairs. And I put this up simply to reflect two conceptual observations. One is the idea that this really is an overarching global outcome score has considerable merit from my perspective. And secondly, it does very firmly introduce the idea of a target goal and where the reality is, and it's all about closing that gap, because that is where the quality improvement process, the rubber meets the road. And this is, I think, one of the ways that are out there to really illustrate this point in a way that can be translated into actionable data on a daily basis. A second concept is this idea of local information and its value, and I would wholeheartedly agree with Chris's last slide that a lot of this activity has been squeezed out of the opportunity, and I think that's missing some enormous data opportunities and quality improvement opportunities. And a lot of this work came from our discussions on the Best Care Document Committee, and a lot of this work comes from Brent James. But the idea is local centers create a core data stream that interfaces with the electronic health record, and this core data stream consists of clinical data, quality data, operational data, financial data, and administrative data. And about 100 hospitals in the country have this down pretty well. We have to bring the other 5,900 up to speed. It sits on top of the electronic health record and becomes the resource for the daily dashboard information which gets produced, and the monthly and quarterly scorecard data, which are how more and more medical entities are running their daily lives and designing what the future is going to be. It also has the attribute of creating the opportunity for just-in-time research, because you can design that, you have the data infrastructure in place, you create a 1- or 2-page data form, it's all electronic,
And 3 days after talking about the idea and getting your IRB approval, you can actually start collecting data to analyze that. And I think this is a huge resource that provides an opportunity at the local level that will continue to feed information and help in the design of core measures and core metrics going forward. It is embedded in the local information systems, and the data are real time, the feedback is in real time, and the learning is in real time. This is an example. These happen to be data from 2007 from our place. We're not even called Pitt County Memorial Hospital anymore. This is an efficiency measure for coronary bypass surgery for 6 surgeons in our group, looking at both clinical outcomes and financial data, true hospital cost of care. And the ODE ratio for mortality is indicated, as well as the cost, and a target cost. And this provider here was in the high cost, low quality domain, and now we know exactly what to do with that physician to get him or her moved in the right direction. This is a different physician in the same data set, and they're down here. And if this one talks to this one and we start to compare practices, we can move this person up here, down here pretty darn quickly. There are also things that are going on at the regional level. This slide's a little difficult to read. But these are data from a regional group looking at clinical information, looking at cost of care, and looking at medical technology. So there are 3 device companies that produce aortic valve prostheses in the United States. And this group of hospitals looked at the cost and quality of all cases who underwent surgery over a period of time, any complication and the costs and incidence of those complications, operative mortality as the singular complication, and then all those patients who got through the operation without any problems or mortality. And as you can see here, just using this line as an example, the rate of any complication with this particular device's valve was 41.4%, but this group of patients consumed 55% of the total healthcare cost in that category. Conversely, the patients who had no complications had a significantly lower cost of care than those patients that had complications. Not surprisingly, but what may be surprising is if you look at different valve technologies, there's no difference across these 3 different technologies. It also illustrates where the money is. If you're going to go after money to reduce healthcare costs, go after the complications and not the mortalities. A word about mortality itself. So mortality is listed in almost every construct of potential core measures. We've had discussions about risk adjustment and the pros and cons of that. I recall back 18 years ago when we sat in a room in Chicago in a snowstorm with the ACC and the STS leadership and went through every single variable in each of our databases at that time. And we agreed that the definitions and specifications for every one of those variables would be identical except for one. And the one that we could not agree on was mortality. And the reason was the ACC at that time defined mortality as mortality that occurred in the cath lab, and we defined mortality as 30-day mortality. So definitions are important, risk adjustment is important, and typically the ODE ratio is the method of expression and comparison of mortality outcomes for the past 15 years. Well, there are emerging understanding that there's a problem with that, illustrated in part by the low mortality incidence of many of these interventions and also by the fact of the variability in mortality that occurs. So this is a different regional group. These are monthly mortalities as a Q-sum, and the variability here is striking, much more than you would anticipate looking at single tabular data. If you have Hospital A and they do 110 cases in a defined period of time and their expected mortality is 1.38 and their operative mortality is 0.9, they have an ODE of 0.66. Hospital B does 239, expected mortality is 2%, observed mortality is 1.25, they have an ODE that's 0.63, they're identical. But if you look at the predicted operative mortality of the patients who died, the patient in hospital A had a predicted mortality of 1.6. The patients in hospital B had a 32% predicted mortality and 8%, 9%, 16% overall. Which hospital is doing better using the same metric? If you were a patient, you would want to go to hospital B because they're killing the right people and not killing the wrong people. We've developed this into a patient-specific performance indicator. Greater than 0 is better and less than 0 is worse. Using the same ODE data, these are ODE data ranked as we typically do with regional initiatives in terms of mortality. Blue is ODE and orange is the PSPI, and there's no correlation between the two. If you ranked hospitals and picked them based on the ODE, you'd be significantly wrong from a PSPI point of view. On the other hand, if positive is better and negative is worse, this gives you a much better indicator of where you should go as a patient to have surgery using the same data construct. This is a observation that I didn't know about until Tuesday night when I was flying up here. We had an informatics committee call for the ACC, and I just thought I'd pass this along as a real-world burial. Maybe you guys can fix this. It had to do with a discussion about the universal patient identifier. The cost to implement the UPI is $1.5 to $11 billion. It's a pretty broad range, but it's somewhere in that, and this number apparently has been known for some time. Kevin may want to comment on this. If we had a UPI and had the same structure that we had now, and in terms of adoption of electronic health records, the return on investment on an annual basis would be 10 to 20 billion a year in decreasing the lack of efficiency that occurs in exchanging health information. And that's 200 billion in 10 years, and now we're talking about enough money to impact on the discussions in Washington now for the fiscal cliff. If you can solve this problem, please help us do so. So this is, the last comment has to do with the technology evolution. This is the mechanism by which we as provider specialists have documented what we do since whenever. We do a procedure, we pick up a dictaphone or the telephone, and we dictate a procedure note. And a lot of the natural language processing efforts, a lot of the problems related to the frustrations with the adoption of EHR have to do with this particular problem. And yet we have not figured out a way to improve upon this process. So what if you had a patient who was in the cath lab and you had a software program that took the information directly from the cardiac cath and translated it through a series of steps, as you see here, into a schematic that was ACC compatible and that provided all of the detail that we currently use to describe coronary anatomy. And that detail happens to be the syntax score, which is what's being calculated right here in real time. This creates not only a pretty picture, it creates an electronic document that contains all of the information in bits and bytes related to what an individual would think about when they look at a cardiac cath film. And then, as it happens in the world in which we live, combining anatomy and functionality is where it's at in ischemic heart disease. And now this is functional data, which is able to be brought into the equation because it's the combination of anatomy and functionality that is driving appropriateness of care in ischemic heart disease intervention. And now we have not only a pretty picture, but we have all of the electronic information behind that picture to be able to capture and use and analyze. And suppose we could do the same thing in the operating room by measuring the change in perfusion that occurs with bypass grafting and then document that in the same way electronically as shown here. This is now an operative note. There's nothing written. There's nothing that has to be searched with natural language. All of the information that accurately describes what's in this procedure is represented in this pretty picture, but it's also in the bits and bytes that are underlying the information that you're seeing here represented visually. And so what we have is a preoperative evaluation and a postoperative evaluation that can now be directly compared, not only visually, but technologically and in terms of bits and bytes. And the quality metrics, appropriateness of intervention, the ability of surgery to relieve ischemia, and all those features are actually built into the representations themselves. So no additional data needs to be collected. You can determine appropriateness of care from this information directly. Intraoperative evaluation of relief of ischemia and or perfusion is illustrated, and it is an entirely new data source that can be embedded in standard practice efforts and documentation to dramatically decrease the work of the data collection that both Kevin and Chris talked about. So in conclusion, I do think there are important new local and regional opportunities in rapid development, and I would certainly endorse trying to reconstitute that balance. It's critical for the specialists who ultimately are going to be greatly impacted on all the core measure work. It does provide the opportunity for real-time data and inferences for decision making, as Kevin talked about, and these technology developments are actually quite robust as they are coming down the pike. I do think it's going to be very important to evaluate the realities of the clinical environment and environments in which the national core metrics will operate, and finally evaluate how well the core metrics can be effectively executed in these clinical environments as these discussions go forward. Thank you.
Thanks, Bruce. Will we have any questions or comments?
I can make a brief comment about the Universal Patient Index. My understanding is that there is federal policy that prohibits HHS from studying or investing in study of a universal patient identifier. So the people that are interested, I would suggest you contract your Congress people, because that is really where we get our direction.
Chris, nice to meet you. We should, no, I'm kidding. But I do have a question about this issue that came up earlier about which population for the triple aim. What are your thoughts about the practicality of having that population be defined as Steve Teutsch's total population or community or geographically defined population versus my population, UW Health or P+ or Aurora?
Well, great question, Pat, and it is nice to meet you. Got to get together sometime. I would say that that's already happening in a couple of communities and regions around our state. The best example that I would point to is La Crosse, where I think by almost every available indicator, and the Dartmouth Atlas is one of the best, it is the lowest or the second lowest per capita cost referral region in the country. And part of the reason for that is there is a holistic concept of how to organize not only the health system but the public health community around drivers of health status and getting fresh food to schools and working on transportation systems and broader social determinants. I contrast that, though, with a metropolitan area like Milwaukee, with all of its complexity, probably one of the most segregated communities in the country by most measures. But at the same time, the Milwaukee health systems, and there's been quite a bit of consolidation in that market, have come together with a very novel collaborative effort called the Milwaukee Healthcare Partnership, which is really focused on trying to improve access to primary care for underserved or uninsured individuals, and is moving beyond that to begin to build relationships with the pastoral community, with the churches, with social services agencies. So I think some of that's beginning to happen, but I would say, though, from the perspective of our measurement work, there still is a tendency to look at primarily the population that's coming to this clinic for care. And so I think we have both the challenge and the opportunity of taking these pockets of innovation and trying to make them more standard across state.
This is really designed for tall people, sorry. Helen Burst at NQF, that was a great set of presentations, and I liked how they built on them, because I had so many questions, and then Bruce got up and asked, and began to answer those. And I'm struck by, if we think about what's happened over the last 2 days, this very big vision of where we want to go, and yet almost none of the discussions yesterday discussed data source at all. It was really data source agnostic. And I think the reality is, to get to this triple aim and this set of principles, it's time to build a sort of a three-dimensional model where one of those dimensions is data source. And we need to start thinking about how you pull in the elegant clinical data out of registries, the really important data that comes out of EHRs, in addition to all the amazing population level data that you have, in a way that starts to make sense. And I think if we do that now in advance of having the metrics, we'll be so much better off than if we wait till the end and then go, oh, that's claims data, and that's public health data, and that's clinical data, and that's in a registry. And I think the time is now. So I'd really encourage us, I don't know if it's the next phase of work, but it's really important to think about prospectively how we would craft that data stream to actually be fitting together and interoperable.
Sue Bakken from Columbia University. My question is for Kevin. One of the things you had on one of your slides was that it was important that things be meaningful and transparent to consumers. And I'd like you to say a little bit more about that in terms of the types of consumers I'm dealing with on a daily basis, which are at great risk for health disparities, may have low levels of health literacy, et cetera, and be a little more explicit about ONC efforts in that regard.
Yeah, absolutely. We have a whole consumer health division. You can look on our website and see a number of consumer-based resources. In order to get the incentive payments, a few parts of transparency need to have occurred. So we're encouraging personal health records. We also are requiring that patients get a summary of their visit after each visit, a sort of computer printout summary. And for Meaningful Use 2, there's a new requirement for a thing called Blue Button, which is a standardized way that a patient could actually download their information directly from an electronic health record, and again, in a standardized format. We anticipate that the really creative marketplace will find ways to turn that standardized information into tools that consumers really need and want to use and collect. Some of this, we're very intentional at ONC that we want to build standards to support innovation on the part of private industry. So we don't want to actually dictate this is exactly how all this stuff is done. We want to take out the middleman cost as much as possible, and then let industry leverage the data and standards and spend their time providing the value that gets the last mile to the customer.
And I'm familiar with some of those resources, but when I don't think they're necessarily those that are needed by the type of people that I'm
Yeah, so as a researcher in health literacy, I mean, that was the place I spent a lot of my time and energy. And I think personally we need a culture change at organizations that want to provide this information in a transparent way to patients. There are only so many levers we have at a federal level. Without this being actually a local act of localization of that exchange of information, we really can't accomplish that at the federal level, I don't think. We have to make sure that the right incentives and drivers are there for the local places to make this happen.
Yeah, the comments by Bruce Ferguson, of course, focus on one very important condition-specific measurement area. I want to expand on something I said yesterday to talk about another in the area of cancer. And this involves the interaction between the local provider of cancer care in hospitals and a national organization. So it's not a link to a federal organization or to the state. And I'm referring in particular to the work of the Commission on Cancer of the American College of Surgeons, which is the COC is the main accrediting organization for cancer hospitals in the country. About 1,400 hospitals are accredited. They deliver about 75% of all cancer care. I happen to be on the Quality Integration Committee of that group, so that's my connection to it. But the point is that they have initiated something now, some of you may know, called the Rapid Quality Reporting System. It is in the early months. It's been alpha tested and beta tested, and now it's been rolled out to the country. About 20% of all the COC approved facilities are doing the RQRS. In fact, 29 of the 43 COC programs in Georgia are doing the RQRS. That is the majority of those hospitals in Georgia. It's something we've pushed, and the question is, what is it? It is a web-based portal operation that allows the individual cancer registry, nurses, providers to enter a parsimonious set of data on each individual cancer patient meeting certain inclusion criteria. The initial work focuses on breast cancer and colorectal cancer. It focuses on adherence to NQF recommendations regarding adjuvant therapy post-surgery right now. And so this data can go in to the web-based portal from the site to the COC headquarters in Chicago, where it is processed. And what that establishes is the ability of the individual hospital site to track these patients over time to see whether or not they are beginning the recommended therapy on schedule. Patients are tracked both at an aggregate at the hospital level and at the individual level. The patient data goes in, and the patient has a white circle. And as the delay continues before therapy starts, the circle becomes yellow. And as the delay continues, the circle becomes red. And then as you get close to the boundary of the guideline, the circle becomes dark red. So this provides an almost near real-time ability to track care. Right now it's focusing only on a few measures. Next year the COC will roll this out and extend it to non-small cell lung cancer and to some additional GI cancers. So and so it does offer an opportunity for quality improvement and also for metric roll-up. The question is how to do that, because this data is not necessarily, in fact, it's not publicly reportable. It's collected by the hospitals, reported to the COC. So how to make this information available to the broader community is another question, but it's a very active program. And the American Society of Clinical Oncology, ASCO, is doing something more ambitious and similar, but on a longer time frame. So cancer is moving forward in this general way.
Just a quick follow-up. You know, what the college is doing is exemplary. The good news in this story is you don't need 15 or 20 years and some uncalculated number of millions of dollars out of the pockets of providers to create clinical national database structures anymore. I'm a very, very strong advocate of the Brookings white paper from 2010 on clinical registries, where the function of the registry national infrastructure is to create benchmarks and provide for resources for programs who want to improve. We learned in our first of our 2 ARC grants with the STS that the sites that started out the lowest but improved the most were the ones that didn't have the resources at hand to be able to do what the big boys were doing. Once you gave them the tools, they performed at exactly the same level. But the data has to be generated locally and it has to be able to be used locally. We live in a healthcare world that moves too fast for 6-month or 12-month or 36-month feedback to say this is how you're performing as an organization. So you got to have the data locally, and any of the 31 medical specialties that don't have database systems with a lot of the work that's going to be generated here in terms of core metrics and the spin-off of the metrics that don't quite meet the core metric but are applicable in these specialty areas could be constructed overnight on an iPad technology that would allow for that information to be collected and stored. That's the state of the art of the technology that exists, and we have to figure out how to take advantage of that.
Yeah, I'd just like to make a comment also. So as a CMO of a hospital, we had 22 of these registries, and we had 17 FTEs supporting the registries. And I watched them, and they would pull up the EHR in here, and then they would go to the web portal, and they were manually typing information from the EHR into the web portal. And so I would challenge us all to work on the standards, figure out, you're not going to get 100% from the data we get out of meaningful use, but there's some percent. It's 10% or 30%, it's demographics, it's something. The more your stuff aligns with what we're asking for those sort of key items like demographics, the the more we can lower the burden on everyone for this duplicative data collection and start building this as a data stream.
Just one quick follow-up. These hospitals are participating voluntarily in this. And so you say, why are they doing it? Because it requires more time. It's because they sense that the norm is shifting. And so, you know, we haven't talked much about carrots and sticks, but the carrot here is that the expectation is going to be moved towards the fact that you would be doing these metrics. So without any additional incentive payments, they're moving in that direction.
Kevin, I wanted to just make a comment about one of your slides where you listed a bunch of the different CMS programs, IQR and OQR and PQRS, and talking about alignment. And one thing that worries me is this focus on, well, you know, we're all for alignment and using meaningful use and HIT to gather that information, so it's not a repeat of what you just mentioned with the registries and having a hand type. But with a lot of effort being put into making sure that some of the lower value measures in those programs are able to be collected, you know, through an electronic environment, it just feels like it might be a waste of resources ultimately versus, you know, there are a lot of measures in some of those programs that just are not pushing the dial and are not really you know, they're not aimed at transforming care. They're added to these programs for various reasons, but transformational care was kind of low on the list. So can you speak a little bit to the just how you balance that effort between making sure there can be alignment of those measures since they are still in play versus transitioning to getting more higher value measures into an electronic platform?
Yeah, I'll speak for Kate Goodrich, who I think has left, but she's leading the charge at both HHS in general and at CMS specifically to really do a in-depth cataloging and analysis of measures, looking at them across a number of domains, including are they doing what we need them to do? And are they sophisticated in ways we want them to be sophisticated? And there is a real commitment to starting to eliminate measures from programs as really the first pass. And then also, HHS has really used the National Quality Strategy to look to develop measures in areas that we think are really important. So for example, I've got contracts to build safety and care coordination measures right now. We're busy trying to build measures to focus on some of these key important topics that haven't had good measures that drive improvement. As Helen knows well, this isn't easy, but we're working hard to make it happen.
As useful as these registries are for individual disease states, and I think they are very, very useful, and they have improved care, I think we should consider a couple of problems now so we can anticipate the future. One is, how are we going to scale these things? And Kevin mentioned 23 different ones in a hospital. That's not an exaggeration. And we don't have a universal identifier, so you can't connect the pieces, so that's a problem. The other thing is we don't have a society of the chronic complex disease practitioners, right? Patients who have complex diseases and chronic diseases who have complex socioeconomic factors account for a lot of resource utilization, and they don't fall into a bucket, right? So that's something we should think about. And then lastly, we should think about transitions of care, because as useful as these individual disease state registries are, and I'm not putting them down, we need another layer which looks at the continuum of care, right? Because the danger is we will have patients in the silos, which is what we're trying to avoid. So I think we should keep these problems in our mind as we build these.
What I'll say from working at a hospital that was lucky enough to have a really rich, robust electronic health record system, we were starting to really struggle with what was the difference between an EHR and a registry, and eventually came to the point that probably a registry is a subset of EHR data that's augmented with intentional outreach to get other data. So, for example, our surgical quality improvement program, the ideal kind of registry feature would be a report that 95% of the data was there directly from care that we generated. 5% was intentionally reached by someone calling the patient at home and saying, hey, did you have an infection we don't know about? Hey, was there something else that happened? But that the EHR became the source and really the primary source of quality improvement, and that the registry then was a subunit of analysis of the overall care system. So then it's actually much more easily reproducible, and you can build it into many different kind of diseases without new burden each time you do that, because it's essentially another report with another disease definition, and you pick the kind of characteristics you want to look at.
And I would completely agree with that, with the understanding that this local river of information generates data. So the cardiac cath diagram that you saw directly, seamlessly imports data into the ACC NCDR. We don't have to collect anything. We're pulling demographic data from the EHR, and everything else clinical is going in automatically. And the same is true for the surgical construct. It's using the technology to do those kinds of things that make the burden of these multiple registries, which don't have to have 700 variables. Most specialty groups could come up with a registry construct that would give them the key things they needed to be able to understand what they're doing and improve quality with less than 100 variables collected by everybody around the country. That technology is available to be able to do those kinds of things. And it couldn't be done without the work of the ONC and everything that's happened with regard to electronic health information in this country. It is complementary, it's not conflicting, and it's an unbelievable opportunity we've got to figure out how to seize.
Randy Siebel, a quick comment and a question. The timeliness of the data acquisition process is obviously key to the kinds of things that you guys are doing, and I think is totally appropriate. And I think that we do need to think about the sources of data and what it is that we expect to have done with them. The one thing that we've been reporting the hospital compare rehospitalization rates for heart failure, for example. Well, so if you want to look at change, or if you want to look at any given report, it is a 3-year rolling average of data that then is one year, probably a year out of sync with this, so it could be as much as 4 years old, and they're expecting the hospitals to be responsive to this, when in fact the hospitals are doing things about transitions of care and reducing rehospitalizations that have no way in hell to be reflected in what this report is. So that's the comment. And I think it's unfortunate that we're using bad sources of data, even though it's accurate and valid. It's true, it's just useless. So I would ask Chris whether or not, since you're doing this whole state, you're able to see pockets of excellence and so forth and so on, whether in fact the counties that are represented by those pockets of excellence, in fact, are those that have higher quality related scores on Patrick's county health rankings.
That's an excellent question, Randy, thanks. And I think the short answer is yes, and Pat could probably answer it more convincingly than myself. But I referenced La Crosse County earlier, and La Crosse has received a little bit of pushback because of their high profile and the recent debate around the Affordable Care Act and their work around advanced directives and things of that sort, as being not representative. It's just a bunch of white people living in that county, and so therefore it's possible for them to have great health status and great quality scores. And there may be something to that, but if you look at some of the other high-performing organizations in our state, in the Fox Valley, up in the Appleton, Green Bay area, but even some of the health systems in the Milwaukee area, they have built cultures of quality that are really focused. They venerate data. They have very sophisticated enterprise-wide data capabilities, bring data to point of not only office practice redesign and point of care redesign activities, but also point of care decision making. And I think they have really elevated the quality. But the sort of holistic view of the triple aim, as I mentioned before, I think is really variable around the state, really variable.
So I would agree with that, Chris. I think the challenge that we see is combining these two geographies or populations. La Crosse has done a good job. Actually, within that collaborative, they combine information from the county health rankings into their whole health referral system. So they've managed to create the crosswalk. I do think the challenge, though, is the response that we often see, which is wanting to control for socioeconomics as opposed to embrace those challenges as part of the aim, so that the reason our health system is not performing well in Juneau County is because we're in Juneau County, as opposed to stepping outside and saying, well, our health system embraces the geography here, and you know, we have a total population aim.
Thanks, Pat. I think that is our last comment, and I just wanted to thank all the speakers before turning it over to Craig. Thank you.
David, thank you. Just want to real briefly close out and thank everybody for the incredible input. What an extraordinarily experienced, knowledgeable group of people that came together for the last 2 days and led such a productive discussion. Far more than I think I could ever have hoped for in terms of producing really good insight around the characteristics and the vision for metrics, how they're being used, and even down to examples of important categories and metrics to lead this discussion forward. It was a great starting point, and there will be follow-on work. It's yet to be determined, and the Institute of Medicine, I think, will be reaching out as their ideas take hold and formulate. And I think also we'll have an opportunity to see what the updated measure examples look like. But this was an extraordinary experience. I came in really hopeful because of what's going on not only in our state but also around the country, and this day and a half, 2 days only reinforced that about all the incredible work that was going on. We started with a great framework of healthcare as a complex adaptive systems, and literally went through an incredible set of examples of how metrics toward the triple aims are guiding many of these complex adaptive systems. And I sat listening to Bruce, watching Bruce's display at the end, wishing that I had a Vermont triple aim dashboard that looked like his cardiology software, and wondering when that's going to come forward. So I just want to thank everybody, but most importantly, I want to thank Peter along the Blue Shield Foundation and Michael and the Institute of Medicine for being willing to take this on and try and act as a catalyst, move the discussion forward, and really move toward metrics being used on a national level to guide the triple aims. I want to thank you very much for that. And most importantly, to thank Rob and the IOM team for putting this together and making it run the way you did. It's incredible. They do a lot on the fly. It may or may not be apparent behind the scenes, and I've come to understand how important Rob's 3x5 index cards are to make things happen as you go. But it's a great team, and they do it incredibly well. Thank you. So with that, I'm going to close out. I can't thank Michael and the group again enough for the opportunity to be part of this. I want to turn it over to Michael. He's the best at bringing all of this together and bring it back to where it started. Thank you, Michael.
Well, thank you, Craig. I think it's virtually impossible to bring all of this rich and textured discussion together, so I won't even try. But I obviously will start with a note of thanks as well to Peter and his colleagues from the Blue Shield of California Foundation for supporting us, and to our our terrific staff for the incredible contribution that they have made. They not only work on the fly, but they work on the ground as well with incredible efficiency. The follow-on tasks are essentially two. One is to write the summary, and the second is to consider the next steps. And in writing the summary, we're going to require your continued input. We'll be trying to capture what we've heard throughout the course of the 2 days in the way of people's thoughts on several dimensions. And someone once cautioned me never to use alliteration, but I'm going to use alliteration this time. As I was jotting things down, there were 8 elements that struck me as particularly important buckets around which to try to capture the issues that have been raised here. First and foremost, purpose. Secondly, the players. Thirdly, the portrayal, and I'll elaborate on each. Fourth, the points. Fifth, the poignance. Am I losing track? I'm losing my own notes. Process, priorities, and prospection. Well, that started it all, unfortunately. You know, I was thinking, well, what's the thing we've heard most about here is parsimony. And so that got me on the P track. Let me just run through each of those quickly. As I said, first and foremost is purpose. It's been stated several times, it can't be stated enough, we need to capture what's been suggested throughout the course of the meeting in terms of the alternatives for the purposes involved. Why core metrics? Are these metrics to emphasize and identify the major factors for better health, better care, and lower costs? Are they to structure rankings? Are they to provide management tools within institutions or organizations? Are they to help structure payment? These are very different kinds of activities. For example, imagine that you're Diana Dooley, the Secretary of Health and Human Services in the state of California, and what you want to do is be able to convince the Centers for Medicare and Medicaid Services that if they give you the flexibility for the administration of the funds, that you will guarantee to deliver on certain core metrics for better care, lower costs, and better health. Well, what is that set of metrics? And what are the levers that they turn to action? So the issue of purpose is obviously very important, and we hope to do justice to the various suggestions about purpose in that respect. The second issue is the players involved. Who needs to be consulted around each of those purposes in the follow-on activities about what's important to them for the set of metrics for their particular responsibilities. With respect to the notion of portrayal, this is a feeble attempt at capturing the notion of the models or the framework. There are different frameworks possibly by different purpose. At least we need to be able as a heuristic to lay out a conceptual framework that is easily engageable by the consuming and using public. So that what we've heard about the kind of frameworks involved is also an important thing to capture. The issue of points is really the data points. What are the examples? We've heard about critical data points that need to be identified. What are the metrics that folks have offered up as possibilities? Next is the issue of poignance, and by that what we're referring to is the need to capture what metrics are particularly poignant in several respects. What are they, for example, targeting different populations? We heard in Kathy's comment about the relevance of disparities and the impact within a given state on the overall status of that state. Which data are particularly poignant in capturing those elements in the best possible fashion that need to be built into whatever set is required? Or what sentinel indicators can be used as umbrellas to trigger local initiative in setting up their own set of metrics and indicators, the sort of modules that Kevin referred to in his comments. So which metrics are especially robust in terms of triggering both initiative and focus on the most important issues? Next was the issue of process, and here this gets to the point that Helen was referring to, which is really vital. How are these data, these metrics going to be reported? Who's collecting them? What are the implications for the collection process, for the ease of their utility? Who's really accountable for actually producing the information? What's available? What needs to be added into the mix in order to ensure that we're developing a set of truly functional metrics for the nation? The issue of priorities is clear. Once we have our set of candidate data points and the identification of those that are particularly poignant, and we have a sense of the processes involved that are necessary to collect them, what are the priorities that we need to use to filter down to the most important in the mix? And then there is the issue that we've really had illustrated in a wonderful fashion, even in the last presentation, of prospection. This is a made-up word because I didn't have a way to capture the future with P. But what we really want to do, obviously, is build, through our set of metrics, to the future, to ensure that we are proposing the kind of evolution of a continuous learning system that allows us to think of metrics as a stream and not as a series of interrupted, punctuated equilibria, if you will. And that's vitally important when we look at the fast-pacing world in which we live. So we will be working within each of those buckets and any others that you suggest to capture the range of issues that have been identified. And we would urge you to offer any other suggestions that you have for including in the mix as we move to develop the summary. The second issue is considering next steps. And as I mentioned earlier, our charge in that respect is to consider whether and how a deeper dive through a formal IOM process might provide a value add, and if so, around which purpose should we anchor? Because it's unlikely that dealing with all purposes is going to yield the most impactful result. And so we need to have your consultation, your advice on that dimension as we sort out the options going forward. And I suppose that's my final plea in many ways, is that as you're leaving and returning to your work at home, you give careful thought to what you think the most important take-home should be for us as we try to set the stage for work that we all can do on this issue in the months ahead. If we do decide to move forward with a more deeper dive into the issue, I think we're very well positioned because of the work that you've all brought to the room and to the discussion. This should not be your typical 2-year IOM activity. We should be able to fast track this sort of enterprise. At least I would hope that that's the case. So once again, I want to thank each of you and all of you for for coming and for bringing such incredible creativity. I've not been, I think, as many meetings as I go to, I don't think I've been to one that has been more stimulating in terms of the importance of the issues and the range of perspectives and the sheer learning process involved as this one. And so it's a great tribute to you. It's a great tribute to our planning committee and our chair. And so in addition to the staff, please join me in concluding with a round of applause for the chair. Happy holidays to all, and we'll look to be continued.